orthodontics, housed with dental operating microscopes for high-quality care, anticipating the best possible treatment outcomes. Orthodontics and maxillofacial orthopedics that provides various types of braces for the correction of irregularly placed teeth and also smile correction for all age groups. Department of Pediatric Dentistry provides wide range of dental treatments to children with special emphasis on prevention of oral diseases in a child-friendly ecosystem. It has the facility to treat children with special care needs and highly anxious children under sedation. Periodontology section takes care of tooth supporting structures with advanced surgical and non-surgical approaches. It also provides fine gum surgeries using lasers and surgical microscope. The Department of Prosthodontics rehabilitates patients' lost teeth and damaged facial parts using novel jaw tracking methods, electromyography and tech scan to achieve promising reconstructive outcomes. Implantology section performs surgeries with various implant systems. This section also offers basic and advanced implantology training program for dental graduates. Oral and maxillofacial pathology section supports diagnosing wide array of oral and jaw diseases at cellular level to identify the root cause and treat them appropriately. The department has high-end equipment like the research microscope and the pentahead microscope to facilitate research and academic activities. The institution has a novel proprioceptive derivation clinic which fosters ergonomic principles among students to inculcate working in stress-free postures during early stages of their clinical training. The Central Dental Laboratory is well organized with unidirectional workflow design for fabrication of high-quality dental prostheses. The lab has CAD/CAM facility which includes the laboratory model scanner, 3D printer and a high-end Ivoclar PM7 for 5-axis milling. The institution runs a unique dental technology twinning program in collaboration with the University of Bolton, United Kingdom. The Central Library facility provides unrestricted access to national and international dental journals, books, reviews and magazines with e-borrowing option. A state-of-the-art 3-tier Central Sterile Supply Department CSSD facility is established for reprocessing and uninterrupted supply of sterile instruments to all the clinical areas. World-class instruments from Finland-based company LM Dental are a part of the centralized instrument repository. The RFID technology is used for instrument tracking. VDC employed high-capacity centralized suction system from Germany for efficient liquid biomedical waste disposal and aerosol control in the clinics. The medical center provides 24/7 medical support with a well-equipped clinical laboratory and pharmacy facilities. the outreach wing at VDC actively engages in conducting free community screening and treatment camps using mobile dental unit to reach remote, rural and tribal places. There are various program initiatives developed as per the oral health needs of the area, including free preventive dental treatments to the needy. The service orientation of Vishnu spreads beyond the boundaries to 8 districts of Andhra Pradesh and 1 district of Telangana, with 32 satellite clinics offering basic and expert consultations to the rural areas. In brief, Vishnu Dental College is an epitome of transformation in dental healthcare education and service provision towards realizing their vision, oral healthcare for all, on par with the global standards.
Team PERIO from Vishnu Dental College extends a warm welcome once again to all the distinguished and dear periodontists on this wonderful learning league platform, the PERIO AKSHAYA. We are proud and happy to bring out the second edition of PERIO AKSHAYA after its successful first edition on non-surgical periodontics that was conducted on 14th and 15th of July 2022. Addressing on the topics of evolution of diagnostic parameters in periodontics by Dr. K. L. Vandana, senior and an eminent periodontist of the country. Periodontal medicine, is it the in thing? By Dr. Muhammad Faizuddin, the legendary periodontist who is often referred as the Bhishmadipati of periodontal fraternity. And decoding 2017 classification being addressed by Dr. K. V. Arun and Dr. Gautami S. Penmetsa, the two dynamic and energetic periodontists who are well known for their academic experience in the periodontal fraternity. This 2-day program of PERIO AKSHAYA proved to be the most interactive session, grabbing the attention of many periodontists across the nation. With this continued zeal, enthusiasm and support from the periodontal fraternity across the country, this second edition of PERIO AKSHAYA brings to you 3 very interesting, exemplary and debatable topics which are also very much need of the hour. The first one would be lectured jointly by Dr. K. Nandakumar, one of the senior most periodontists of the country, and Dr. Vishwachandra Rampalli, the man behind periobiologics, on the very much awaited topic, is flap surgery being undermined in this era of implantology? The second one would be addressed by Dr. John Pauline George and Dr. Vinita Gupta, the proud alumni of the College of Dental Sciences, Davangere, on the most inquisitive topic, mucogingival surgery. Is it a boon or a bane to attach a gingiva? And last but not the least, Dr. L.B. Peter, an eminent orthodontist, and Dr. Ravi Kiran, the dynamic periodontist, are charged up for the most debatable topic, ortho-perio nexus, bonding and attachments, in the second edition of PERIO AKSHAYA. So dear all, your active involvement and enthusiastic participation in this second edition of PERIO AKSHAYA is invited and awaited. Happy learning. Thank you.
Good morning, Arun sir. Good morning, Arun sir.
Good morning.
Nice to see you after so long.
Very nice to see you too. So I
Just 20 minutes more to go, sir.
oh okay. So we are early, is it?
Yes,
Okay,
sir.
okay. Then I'll just go take a round and come then. I thought 9:30, huh?
No,
I'm
sir.
sorry, I made a mistake.
No, sir. Nice to see you. Without any technical hitch, I think you have really learnt it.
No. Actually, I am at home today because I am worrying about my college connection. So that is why it is clean.
Sir, most of the colleges in Chennai are closed today because of the cyclone.
Flooded cyclone.
And my daughter's college is closed today and tomorrow. So that's how I came to know.
So everything is closed today. So we are working from home.
Sir, lucky people, sir. Half of the time Chennai is affected with cyclones and you have holidays.
Yeah. Hello.
Good morning, sir. Nandakumar sir. Nandakumar sir, you can come online. I've seen you on YouTube. Sir, we have forwarded it to most few orthodontic groups also, so that we'll have a good discussion. Let's see how many will really take it up. But yesterday, people were really appreciating, sir. The 2 sessions went on well, and more of interaction on flap surgery, the most heated topic actually.
Very good.
Eager to meet you offline, sir. Avlokan is going to come up early 23.
23. Very good.
Fed up of this online.
Yes.
Few programs are unavoidable, but then I think Avlokan we can shift off offline.
Correct. Best shifted offline. We are always happy seeing people face to face.
Yes, sir.
Something you will think, okay, then there is no technical hits, things are going all right, then suddenly something will crop up.
Yes, sir. Morning we have to change the Zoom link and again send everyone the new link. Like this, when technical hitches arise, we really feel
correct.
Sometimes.
Otherwise, how are things?
Ma'am, good morning, ma'am. Rekha, ma'am. So happy to see you. Ma'am, can you unmute yourself? Can you unmute?
Yeah. Yesterday, I couldn't participate throughout. I had some personal commitment. But I did on and off. I was listening to Dr. Jayakumar and Dr. Nandakumar, sir. There was a nice, good debate.
Ma'am, then I think you came at the right point. Don't think you have missed it.
Hi, Arun.
Hello.
I see Dr. Rohit also. Nice to see you, Dr. Rohit. Dr. Rohit Prasad from Ramaya.
So I think we'll join back at 10, Gautami. Is that correct?
Yes, ma'am. 9:50.
Okay, fine.
We'll join at 9:50.
All right.
And please send a link to your department.
Definitely, I'll do. I'll do that.
Ortho also. Okay.
Sure.
Thank you so much, ma'am.
Yeah.
Vishnu Dental College and Hospital is in Bhimavaram, West Godavari district of Andhra Pradesh. Established
Team PERIO from Vishnu Dental College extends a warm welcome once again to all the distinguished and dear periodontists on this wonderful Learning League platform, the PERIO AKSHAYA. We are proud and happy to bring out the second edition of PERIO AKSHAYA after its successful first edition on non-surgical periodontics that was conducted on 14th and 15th of July 2022. Addressing on the topics of evolution of diagnostic parameters in periodontics by Dr. K.L. Vandana, senior and an eminent periodontist of the country. Periodontal medicine, is it the in thing? By Dr. Muhammad Faizuddin, the legendary periodontist who is often referred as the Bhishmadipati of periodontal fraternity. And decoding 2017 classification being addressed by Dr. K.V. Arun and Dr. Gautami S. Penmetsa, the two dynamic and energetic periodontists who are well known for their academic experience in the periodontal fraternity. This 2-day program of PERIO AKSHAYA proved to be the most interactive session, grabbing the attention of many periodontists across the nation. With this continued zeal, enthusiasm and support from the periodontal fraternity across the country, this second edition of PERIO AKSHAYA brings to you 3 very interesting, exemplary and debatable topics which are also very much need of the hour. The first one would be lectured jointly by Dr. K. Nandakumar, one of the senior most periodontists of the country, and Dr. Vishwachandra Rampalli, the man behind periobiologics on the very much awaited topic, is flap surgery being undermined in this era of implantology? The second one would be addressed by Dr. John Pauline George and Dr. Vinita Gupta, the proud alumni of the College of Dental Sciences, Davangere, on the most inquisitive topic, mucogingival surgery. Is it a boon or a bane to attach a gingiva? And last but not the least, Dr. L.B. Peter, an eminent orthodontist, and Dr. Ravi Kiran, the dynamic periodontist, are charged up for the most debatable topic, ortho-perio nexus, bonding and attachments, in the second edition of PERIO AKSHAYA. So dear all, your active involvement and enthusiastic participation in this second edition of PERIO AKSHAYA is invited and awaited. Happy learning. Thank you. Team PERIO from Vishnu Dental College extends a warm welcome once again to all the distinguished and dear periodontists on this wonderful learning league platform, the PERIO AKSHAYA. We are proud and happy to bring out the second edition of PERIO AKSHAYA after its successful first edition on non-surgical periodontics that was conducted on 14th and 15th of July 2022. Addressing on the topics of evolution of diagnostic parameters in periodontics by Dr. K. L. Vandana, senior and an eminent periodontist of the country. Periodontal medicine, is it the in thing? By Dr. Muhammad Faizuddin, the legendary periodontist who is often referred as the Bhishmadipati of periodontal fraternity. And decoding 2017 classification being addressed by Dr. K. V. Arun and Dr. Gautami S. Penmetsa, the two dynamic and energetic periodontists who are well known for their academic experience in the periodontal fraternity. This 2-day program of PERIO AKSHAYA proved to be the most interactive session, grabbing the attention of many periodontists across the nation. With this continued zeal, enthusiasm and support from the periodontal fraternity across the country, this second edition of PERIO AKSHAYA brings to you 3 very interesting, exemplary and debatable topics which are also very much need of the hour. The first one would be lectured jointly by Dr. K. Nandakumar, one of the senior most periodontists of the country, and Dr. Vishwachandra Rampalli, the man behind periobiologics, on the very much awaited topic, is flap surgery being undermined in this era of implantology? The second one would be addressed by Dr. John Pauline George and Dr. Vinita Gupta, the proud alumni of the College of Dental Sciences, Davangere, on the most inquisitive topic, mucogingival surgery. Is it a boon or a bane to attach a gingiva? And last but not the least, Dr. L.B. Peter, an eminent orthodontist, and Dr. Ravi Kiran, the dynamic periodontist, are charged up for the most debatable topic, ortho-perio nexus, bonding and attachments, in the second edition of PERIO AKSHAYA. So dear all, your active involvement and enthusiastic participation in this second edition of PERIO AKSHAYA is invited and awaited. Happy learning. Thank you. Team PERIO from Vishnu Dental College extends a warm welcome once again to all the distinguished and dear periodontists on this wonderful Learning League platform, the PERIO AKSHAYA. We are proud and happy to bring out the second edition of PERIO AKSHAYA after its successful first edition on non-surgical periodontics that was conducted on 14th and 15th of July 2022. Addressing on the topics of evolution of diagnostic parameters in periodontics by Dr. K.L. Vandana, senior and an eminent periodontist of the country. Periodontal medicine, is it the in thing? By Dr. Muhammad Faizuddin, the legendary periodontist who is often referred as the Bhishmadipati of periodontal fraternity. And decoding 2017 classification being addressed by Dr. K.V. Arun and Dr. Gautami S. Penmetsa, the two dynamic and energetic periodontists who are well known for their academic experience in the periodontal fraternity. This 2-day program of PERIO AKSHAYA proved to be the most interactive session, grabbing the attention of many periodontists across the nation. With this continued zeal, enthusiasm and support from the periodontal fraternity across the country, this second edition of PERIO AKSHAYA brings to you 3 very interesting, exemplary and debatable topics which are also very much need of the hour. The first one would be lectured jointly by Dr. K. Nandakumar, one of the senior most periodontists of the country, and Dr. Vishwachandra Rampalli, the man behind periobiologics, on the very much awaited topic, is flap surgery being undermined in this era of implantology? The second one would be addressed by Dr. John Pauline George and Dr. Vinita Gupta, the proud alumni of the College of Dental Sciences, Davangere, on the most inquisitive topic, mucogingival surgery. Is it a boon or a bane to attach a gingiva? And last but not the least, Dr. L.B. Peter, an eminent orthodontist, and Dr. Ravi Kiran, the dynamic periodontist, are charged for the most debatable topic, ortho-perio nexus, bonding and attachments, in the second edition of PERIO AKSHAYA. So dear all, your active involvement and enthusiastic participation in this second edition of PERIO AKSHAYA is invited and awaited. Happy learning. Thank you.
Good morning, Dr. Prakash. Good morning, Dr. Srinivas. Good morning, Shiv Kumar sir. I can see Dr. Anand sir also online. Good morning, sir.
Good morning, Gautami.
Very nice to see you on the PERIO AKSHAYA platform. I think only the topic might have really clinched you, sir. PERIO ortho interrelation or PERIO ortho nexus.
Yes.
Yes,
and probably the other association I have is Dr. L.B. Peter was my senior and a very close friend. He was also my teacher during my MDS times. And so definitely it would be a privilege to hear his lecture. And more than anything, I think the cross thought process in both the specialties is very much needed and essential. I think both orthodontists as well as periodontists have to understand that the interaction should be much greater than what it is now. And I guess probably the lecture today would open all our eyes. And I'm sure at Vishnu, the way we are going to teach ortho patients is going to change after this lecture. And it's a topic which I would love to hear.
Thank you so much, sir. Dr. LB sir, I've heard so much about you from Dr. Anand sir that all these people used to read your notes and you were the most dedicated and most disciplined senior. That's what I've heard from Dr. Padmapriya also. Moreover, we heard you during Ortho Perio Colloquium, sir. That's the reason why we wanted you very strongly on this platform.
Thank you, Dr. Gautami, and thank you, Dr. Anand, for your kind words.
I see Dr. Srinivas Nagarkanti, who is now heading the Department of Periodontics at Nellore. Welcome, Dr. Srinivas. I can see Dr. Prakash, PSG from Chennai, the man behind lasers, who really practices lasers hard and core. Welcome, Dr. Prakash.
Morning, ma'am.
I can see Dr. Shivkumar sir, principal of Amlapuram Dental College. Welcome, sir. I can see Dr. Rajesh Kashyap, Dr. Raghavendra, Dr. Vinita, who have been really on the show since yesterday and have been getting so many messages. I see Dr. Durga Rao, who is my senior. Welcome, sir. And who is heading the Department of Periodontics at Malla Reddy. Good morning, Durga Rao, sir. I think we can start. It's already 10:02. Now coming to the second day of the most awaited PERIO AKSHAYA. My postgraduate, Dr. Shravanti, would take over the
Good morning, Dr. Gautami.
Good morning, sir.
Best wishes for the program. You are doing a great job.
Thank you so much, sir.
Yeah. Looking forward for more programs ahead like this. Best wishes, Amma.
Sure, sir. Thank you, sir.
Thank you, ma'am.
Good day.
Thank you, sir. We'll start the programs.
A very good morning to all. We Team PERIO of Vishnu Dental College thank each and everyone for being with us here today. The most awaited second day of PERIO AKSHAYA is about to start. It gives me immense pleasure to welcome all the dignitaries for the second day of PERIO AKSHAYA. We Team PERIO of Vishnu Dental College are overwhelmed with the positive responses of the first day. Let's kickstart our second day with the most debatable topic, Ortho-Perio Nexus, Bonding and Attachments by Dr. L.B. Peter and Dr. Ravikiran N.
And the session of Dr. L.B. Peters will be moderated by Dr. K.V. Arun, sir. And we take the privilege of inviting Dr. K.V. Arun, sir. Dr. K.V. Arun completed his BDS and MDS from Government Dental College, Chennai. And he is currently heading the head of the department, and he's also the professor at Ragas Dental College and Hospital, Chennai. He has authored textbooks titled Molecular Biology of Periodontium for Postgraduates and Exam Preparatory Manual for Undergraduates in Periodontology. He has several international and national publications, including Periodontology 2000. He is recognized as a PhD guide of the Tamil Nadu Dr. MGR Medical University and has obtained several grants from government agencies. He has lectured and conducted surgical demonstrations and hands-on workshops in national level flora, on various aspects of periodontal surgery and implantology. And I would like to, it's my indeed a great pleasure to welcome Dr. Arun sir onto this online platform. The session is yours, sir. And you can please introduce Dr. L.B. Peter.
Yeah, thank you. Thank you. Am I audible?
Yes, sir. Yes, sir. You're audible, sir.
Yeah. So it is always a great pleasure to invite an orthodontist to our platform because of two reasons. One, aside from the CV that was read to you, the other thing that is important today is orthodontics and me have always been it's been a mystery to me from the undergraduate days where people used to bend the wire under the table and give it to me. And it is all the more interesting now because I could never bend a wire to save my life. And it is therefore very interesting to invite a person who is not only a PhD, armed with a PhD from the Kerala University, but also an apparently a law degree. So that seems to be a rather strange combination. It is very interesting to therefore welcome Dr. L.B. Peter, who is currently professor in Kottayam Dental College, and he has a number of publications to his credit. And there is very little more that I need to say. We will go ahead and share the platform with him directly so that I don't waste your time with my introduction. Thank you.
Thank you, sir. Dr. L.B. sir, we'll start the session.
Okay, ma'am. Okay. A warm good morning to one and all. I take this opportunity to thank the team PERIO of Vishnu Dental College for organizing this PERIO AKSHAYA and successfully conducting it for the second time. My special thanks to Dr. Gautami ma'am for extending the invitation to me. And I also thank Dr. Ravi Kiran for coordinating and helping me in organizing this session. Vishnu Dental College has got a special place in my heart because its director, Dr. Raju, is a close friend of mine. Dr. Padma Priya is also there. And it's a proud honor and privilege for presenting this in PERIO AKSHAYA. Myself, Dr. L.B. Peter, Professor of Orthodontics, Government Dental College, Kottayam. I consider dentistry to be a tree in which all specialities are its branches, and ortho and perio are no exception. Orthodontics and periodontics has got its own core area, which is independent to each other. But at the same time, when they merge each other, there are certain overlapping areas. For example, for enhancing aesthetics, enhancing post-orthodontic treatment stability, to facilitate restoration, to facilitate healing, etc. My topic outline is orthodontics in periodontology perspective, wherein I will be dealing with the basics of ordinary orthodontic tooth movement and orthodontic treatment in periodontally compromised patients, where we will see some case study, and phrenectomy, when and how of phrenectomy, and advanced ortho-perio interaction, basics of accelerated orthodontics. To begin with, let us recapitulate the basics of orthodontic tooth movement. There are two sources of force on a tooth. One is by the natural force, including the muscular force and the functional force. The second source of force is orthodontic force. The functional force is usually very heavy, varying from 1 kilogram to 50 kilogram, and is momentary in nature, whereas orthodontic force is light but continuous in nature. The periodontium is well adapted to bear this heavy and momentary force, whereas it yields to the continuous light force applied by orthodontic means. When a single force is applied to the crown of the tooth, there is a tendency for the tooth to tip. Now, if we want a bodily movement, we have to opposite a counterbalancing force in the opposite direction. When such a force is applied, it can bring about bodily movement where there is compression of one half of the periodontal ligament, and there is, or that site is called the pressure site. Obviously, there is a reduced oxygen tension following this compression, leading to release of first messengers, prostaglandins and cytokines. This prostaglandins and cytokines will start intracellular signaling, leading to the release of second messengers, CAMP, CGMP, etc. This will act upon the osteoprogenitor cells, leading to its transformation into osteoclast, and bone formation begins. Whereas at the tension site, there is stretching of the periodontal ligament. This leads to an altered blood flow, and osteoblasts are being formed over there, leading to bone deposition. So this osteoclast induced bone resorption and bone deposition, together known as bone remodeling, is what is happening with orthodontic force application. Now, as I mentioned before, time is the critical factor. Now let us see what happens with time after orthodontic force application. So when a single force is applied to the tooth like this, within 1 second, the alveolar bone bends and piezoelectric signals are generated. 1 to 2 second time, the tooth movement occurs within the periodontal ligament. Within 3 to 5 seconds, there is pressure and tension zones, and the cells are mechanically distorted. Within a minute, the oxygen tension changes, prostaglandins and cytokines are released. Within hours, the metabolic change starts happening, and within 4 hours, the second messengers starts to appear and induce cellular differentiation. And within 2 days, orthodontic tooth movement starts because osteoclast and osteoblasts are formed. Now, the heavy force, when it is applied to the tooth also, almost same event happens with slight change. For example, there is total compression and total stretching of the periodontal ligament, leading to cell death, hyalinization, and this leads to undermining resorption, where there is a delay in orthodontic tooth movement. One thing we have to be bothered of or remembering is the width of the alveolar bone is maintained due to compensatory resorption and deposition. Many a times the tooth can be moved more than its width as such. This is because of the compensatory resorption and deposition that is happening, followed by orthodontic force application. Now, this article by Krishnan V. et al., published in 2006 AGO-DO, enumerates the entire list of factors affecting bone remodeling following orthodontic tooth movement, including hormones, growth factors, cytokines, colony stimulating factors, etc. Now, with that basic recapitulation of tooth movement, I move on to the second part, that is orthodontic treatment in periodontally compromised patients. Now, this picture is post-PERIO treatment of patients with chronic periodontitis. Now, is our treatment over at this stage? Now, if we are finishing off at this stage, remember, we are preventing the patient from the full enjoyment of the benefit of orthodontic tooth movement and enhancement of aesthetics. Suppose if we decide to go ahead with orthodontic tooth movement, the question is, how safe is orthodontic treatment in patients with reduced periodontium? There are various articles which says that orthodontic treatment is no longer a contraindication in patients with periodontitis after its successful treatment. In these cases, orthodontic treatment can be in fact beneficial for the patient. Suppose we have decided to go ahead with treatment, the next question is, how do we sequence treatment in periodontally compromised dentition? Obviously, there are 3 stages. The pre-orthodontic periodontic phase, where the disease is controlled. This is followed by orthodontic phase, usually 6 months after completion of phase 1 therapy. Suppose if there is a regenerative therapy being done, it would be better to start the case little early. And finally, there is a post-orthodontic stabilization phase. Now, this is a case of pathological migration. At the end of periodontal treatment, there is recession, extrusion, flaring, diastema, and missing papilla. So we undertook treatment with superelastic copper nitride wires, which apply very light and continuous force and very helpful or very friendly with the periodontium. And at the end of treatment, we achieved intrusion, alignment, leveling of CEJ, better papillary aesthetics, and recession also found to be less. This obviously needs a post-treatment fixed lingual retainer as a stabilization appliance. Here in this case, the patient had chronic periodontitis with generalized bone loss. So this is at the end of the perio phase where the disease is completely controlled. Then again, we initiated post-perio orthodontic treatment and finally finished with permanent retainers. So what I wanted to highlight here is not just healthy periodontal treatment is sufficient for a patient with pathological migrations or chronic periodontitis. We need to enhance their aesthetics and bring or uplift their smiles too by undertaking orthodontic treatment also. The next aspect of this segment is periodontal healing outcome. There are various histological evidences published in orthodontic journals which highlights that there is no detrimental effect on periodontal healing by some articles, and other articles says that there is significant new attachment formation after regenerative periodontal therapy when orthodontic treatment is undertaken. If that was the evidence in orthodontic journals, periodontal journals also support the view that orthodontic tooth movement started early after periodontal surgery will enhance the bone fill. We also have evidences from case reports, case series, which have follow-ups up to 12 years supporting this concept. Even though it forms to the base of the evidence pyramid, it states that it highlights the benefit of orthodontic treatment, especially with intrusion of tooth. Here is a case where there is bone loss and pocket, which was regenerative periodontal therapy was undertaken, and it is healed after the healing orthodontic therapy was undertaken 6 weeks after the periodontal surgery. And here is another case with 8 millimeter deep periodontal pocket was observed and there was bone loss. So periodontal regenerative surgery was undertaken, and after the initial healing phase, we undertook orthodontic treatment after 1 month, and this is 6 months of orthodontic treatment, showing there is a reduction in recession, papillary fill, etc. One thing we have to be very careful when we are undertaking intrusion in patients with periodontitis is when we are intruding the tooth to the bone, the supragingival plaque can shift into a subgingival position and initiate angular bone loss. Hence, the need for the phase 1 therapy is very important before undertaking orthodontic tooth movement. Here is another case where orthodontic intrusion has been undertaken to treat recession and papillary fill. This was supported by evidence from Quadrupoli et al. And Reyes et al. Next, we move on to implant site development with orthodontic help. Orthodontic extrusion can bring about alveolar bone along with it. That is the basic principle. When a tooth is moved out of the socket, depending upon the nature of tooth movement, if it is slow extrusion, we can bring about or we can move the alveolar bone along with it, and finally leading to atraumatic orthodontic extractions, and to this area implants can be given. This case had a hopeless tooth which is now not considered as a useless tooth, and this lady had 1-1 and 1-2 with advanced bone loss, and the treatment plan for this was to undertake orthodontic extrusion and slow extraction of the tooth followed by fixed replacement using prosthesis. Now, when we look into the literature, we have evidences from Salama et al., Amato et al., who have highlighted that implant site can be developed by orthodontic forced extraction. So we undertook orthodontic extrusion in this case. The tooth was priorly treated with root canal treatment, and progressive incisal reduction was undertaken as the tooth was extruded. And finally, the tooth was moved totally out of the bony socket. Immediate implant placement was undertaken because immediate placement avoids bone and soft tissue loss due to remodeling. And finally, the restorative work was undertaken and the case was finished. 2-year follow-up also shows that there is sufficient bone and the bone fill is being maintained, and even a 5-year follow-up also showed favorable retention of the results. This article highlights the guidelines for orthodontic tooth extrusion for implant site development. We should be using a very light force of 15 grams for anteriors and a slow rate of extrusion less than 2 millimeter per month. Application of palatal root torque is very important during the extrusion process, which I will explain in the next slide. And after force application, stabilization for another month is very essential for each month of force application. Now, this is to ensure that the tooth is moving out of the socket along with the alveolar bone. Now, here is the importance of counterbalancing force or torque to be applied during the process of extrusion. Now, the force need to be applied along the long axis of the tooth so that it could be moved out of the socket. When the root of the tooth goes and touches the labial cortical bone, there is chance for fenestration, and this will destroy the labial cortical bone and implant placement cannot happen then. So here comes the need of counterbalancing or the torque force. So when a force is applied on the labial surface of the crown for extruding, what happens is that due to a distance from the center of resistance to the point of force application, there is rotation of the tooth, which leads the root to move labially, and there is chance for fenestration, and there is torque loss. This is what is happening when the tooth is moved out of the socket like this. The labial cortical bone is lost. To overcome this, a counterbalancing force or a palatal root torque is applied to the tooth that is being extruded, which will force the root to the posterior or to the palatal wall. And as the tooth is extruded, the labial cortical bone is maintained. Now, this is a case where a female patient reported to as for congenitally missing upper lateral incisor. We know that the congenitally missing upper lateral incisor is very prevalent, 3.8%, and it is more in females. The treatment plan was to close the midline space and create space for replacing the lateral incisors. Accordingly, we moved the tooth, and finally we understood that on 1-2 side implant placement was not possible because sufficient space for the implant was not achieved, whereas on 2-1 side, 2-2 side, it was possible. Hence, an immediate implant placement was done, and it was rehabilitated one side with a Maryland bridge and other side with an implant. Next, we will see orthodontic extrusion for crown buildup. When a tooth is moved out of the socket, if you are undertaking it at a rapid pace, along with or without fibrotomy, we can move the tooth out of the socket. When fibrotomy is not performed, it might bring the alveolar bone along with it. Here is a case where a 20-year-old patient reported with fractured jacket crowns. The tooth was priorly treated with root canal treatment. So the procedure undertook was to reduce the restoration from the root canal filling from coronally, and space was prepared for post, and orthodontic extrusion appliance was fixed, and tooth was extruded to the place. Here we can see the alveolar bone is also carried along with the extrusion process. Then finally, the restorative work started with incisions and exposure, followed by osseous recontouring, and a favorable crown to root ratio was achieved, and at least of 1:1 ratio should be achieved for restoration, and adequate crown structure has been prepared, and permanent crowns were fixed. 5-year follow-up also showed that the crown root ratio is adequately maintained and the tooth is intact in place. Now we can also think of pocket elimination in certain cases, which orthodontic treatment can enhance this process, especially when mesially inclined molars due to missing first molar or second molar is encountered. We can either tip the tooth distally or the root can be moved mesially. And finally, the tooth can be supra-erupted so that the bony, the fill can be achieved and the periodontal pocket can be eliminated or to reduce to a great extent. Various orthodontic mechanisms are usually done for this. For example, loop mechanics is very commonly done. When a loop is inserted like this, the tooth crown will tip distally like this. Another commonly or recently practiced approach is to go for implants, where implants are being placed into the retromolar area and elastic chains can be applied and the tooth can be uprighted. Now, when the tooth is uprighted, you can make a decision whether to go for a restoration or you can consider even mesializing the tooth with the help of implant or any other mechanics and close the space also. Now, there are certain basic treatment plannings in orthodontic will help to avoid periodontal problems. For example, in this case, the second premolar was totally blocked out. Generally, we have a tendency to prescribe extraction of the second premolar because it is very easy for the orthodontist. But what happens is that when an extraction is performed like this or surgical removal is performed, there is a bony defect that is formed which will never get filled up. So the best option would be to go ahead with the first premolar extraction, retain the space with the anchorage reinforcement measures and let the tooth erupt into the oral cavity. Now this will bring the alveolar bone along and a permanent bony defect can be prevented. There are few other problems also faced by orthodontists, which I wanted to highlight. The first one is envelope of discrepancy. Envelope of discrepancy highlights the range of orthodontic tooth movement that can be achieved by various means. By means of orthodontic tooth movement alone, by means of functional appliances, by means of temporary anchorage devices, and finally using surgical procedures. Many a time for borderline discrepancies, when we suggest a treatment planning method, mostly the patients will reject this and we opt for a less invasive method, which we call it as camouflage. When camouflage is done, usually the tooth movement may be undertaken at the expense of periodontal health. And there are certain unavoidable side effects of orthodontic treatment which we can only reduce to certain limit. For example, a growth modification treatment undertaken using functional appliance. When fixed functional appliances or removable functional appliances are given, there is invariably some amount of lower incisor proclination. This is also seen in cases with the class 2 elastics and class 3 elastics also. Now, these are certain unavoidable situations which we can only reduce to some extent. Now, when incisors are proclined like this, what eventually can happen in future is gingival recession. This article highlights the extent of gingival recession, which will be covered little later. And there are certain biomechanical limitations also, which I would say periodontists should understand in a periodontally compromised cases. We know that when a force is applied to the tooth, it should pass through the center of resistance to get a bodily movement. Otherwise, the tooth will tilt or tip. What happens in periodontally compromised dentition is there is bone loss and the alveolar bone or the marginal bone is shifted apically. This will also shift the center of resistance also to the apical position. So when a single force is applied, the tendency for tipping the tooth will be very high. And to prevent this, we need to apply a counterbalancing force from the opposite direction. Now, such a counterbalancing force will be very high magnitude, especially when a case that is periodontally compromised. For example, if 100-gram tipping force is applied, to prevent the tooth from tipping, 1000 grams of a counterbalancing force need to be applied. That means 10:1 ratio. This will be too much for a case of periodontally compromised situation. Another important issue is that, especially for a group of teeth, for example, in lower incisors, when there is differing levels of bones, what happens is that each tooth will have a different center of resistance. Hence, the control of the tooth is mostly arbitrary in cases with periodontal bone loss. Now, this is a slight compromise that we did using mechanics, where the patient did not opt for interproximal stripping. Here we can see this patient having a black triangle, and that was her complaint. Ideally, we could have gone for interproximal stripping and mesialize the tooth or close the space, which would have been better for her. But she did not opt for IPR, and we had to modify the mechanics. We used a wire bending with artistic bends and tipped the tooth, the cervical portion, close to each other and reduced the black triangle. And this is 2 years after the treatment. Now, with that, I finish my first aspect and I move on to the next one, that is frenectomy, when and how. Frenum and diastema has got a cause-effect relationship. This is one of the earliest articles that we find in orthodontic literature regarding the cause-effect relationship of frenum, which highlights that 80% of subjects with high labial frenum had a diastema. Now, there are 3 issues surrounding a labial frenum, that is, does it contain muscle fiber, when to surgically remove it, and which all cases need surgical removal. We know that maxillary labial frenum is a post-eruptive remnant of tectolabial fold. Now, there are conflicting views regarding what is the content of the maxillary labial frenum. Some authors supporting the presence of muscle fibers, whereas others have denied it. A current view put forth by Henry Levin and Sakins is that there is dense collagen and elastic fibers and no muscle fibers identified in the frenum. Now, there are controversies regarding the timing of frenectomy. The periodontist or the surgeon's view was initially prior to the orthodontic closure. Now, the advantage they attributed were it overcome the soft tissue resistance for orthodontic closure, and complete excision is possible when there is a diastema between the tooth. However, the concern is that the scar tissue prevents complete closure. Now, another school of thought which the orthodontists maintained until recently was to close the diastema after the frenectomy to be done after orthodontic space closure. The advantage they put forth was rapid closure because of the lack of soft tissue, the scar resistance, and the scar tissue formed will retain the correction. However, the drawback is complete excision becomes difficult. Now, we looked into the literature, and the current view put forth by Naini and Gill is that the frenectomy may be undertaken when the incisor teeth are orthodontically aligned and space closure is imminent, or partial closure has been done, or even complete closure has been done for a minor diastema. So that is the current view. A Blanch test is diagnostic of high labial frenum, but it is not indicative for its surgical excision. Now, the advantage of this method is there is sufficient interdental space to carry out surgery safely in case of a large diastema with a fleshy frenum. But if in case of a small frenum, the space can be completely closed and then frenectomy can be undertaken. The space closure can be resumed immediately after surgery, and scar formation also may help in retaining. Now, which all frenum need to be removed? Does all frena need to be clipped or removed? Now, no frenectomy should be done before the eruption of upper 6 anteriors. Here again, there is a need-based school that has been put forth where all frenums need not be removed. It should be removed only if it is thick, fleshy and low attached frenum, which is unattractive in nature, especially if it is affecting oral hygiene maintenance and there is recurrent trauma due to tooth brushing. Also, if it is attached to the upper lip and leading to hypomobility. Now, in government college, we don't treat all the cases with fixed appliances because of the heavy rush that we have. Here is a case that we have treated a diastema using a simple split labial bow appliance, and the frenectomy was performed after the space has been closed. Whereas this case had about 4 millimeter diastema and a thick, very thick, fleshy frenum. So we partially closed the closed the space and removed the wire and sent for frenectomy. And then frenectomy was done, and after the healing, wire was replaced back and the space closure was completed. So the question has been resolved. There is no evidence of muscle fiber in a frenum, and it is technically or ideally done during or towards the end or even after orthodontic treatment, and a need-based school, so every frenum need not be removed. Now, I am sure I need not elaborate much on the how of frenectomy to this learned crowd of periodontists. There are various procedures that has been done, and of course, I leave this topic for you to ponder upon. And I move on to the last part of the presentation, that is advanced ortho-perio interaction, that is accelerated orthodontics. Now, the moment you strap up an orthodontic case, the immediate next question from the patient will be, doctor, when can I remove the appliance? When can I get the appliance removed? Now, when we look into literature, there are various methods of accelerating tooth movement, surgical as well as non-surgical. This Cochrane systematic review have highlighted that only surgical means can really bring about an acceleration in orthodontic tooth movement. This case reported to us with a bimaxillary protrusion on a mild class 3 skeletal base. If you closely look, you can see the labial cortical bone is very thin. There is a thin biotype, and the bone is the root is very much visible outside. And she was about to get married, and she wanted the treatment to be fastened up. We undertook, after initial alignment, when the case was about to retract, we undertook a classical corticotomy, and we undertook orthodontic tooth movement and completed the treatment. And 5 years into retention, the case is well maintained. The recession or nothing is there in the labial anterior segment. It is well maintained. Now, corticotomy has got several indications. Like, for example, it can convert a borderline orthognathic case into a orthodontic case. Also, to accelerate orthodontic tooth movement. The advantages being it is less invasive, less costly, and less risk to the periodontium. There are various means of corticotomy. The classical one that is suggested by Wilco et al. Is the periodontally accelerated osteogenic orthodontics, where buccal and labial, lingual and labial flaps are being opened up, and bone grafting is performed, and tooth movement is undertaken, which will enhance the bone formation and accelerate tooth movement. Now, a segmental approach is also possible, where the flap is reflected only on one side to the direction of tooth movement. And less invasive methods like a piezo scission using a piezo handpiece and micro osteoperforations using devices can be also carried out. The basic principle is selective alveolar decortication, and this is followed by bone grafting and orthodontic force application, resulting in regional acceleratory phenomenon. Now, piezo scission is a method where a less invasive procedure can be undertaken using piezo scalpel. We undertook this study in our department using for piezo scission, and another one using micro osteoperforation, in which we used a indigenous mini implant as a source for inducing perforations rather than the classical device called Propel that has been suggested, which is an expensive device. And 1.5 to 3 millimeter depth perforations have been done to enhance orthodontic tooth movement, and results showed that there is significant increase in tooth movement following this method. So with that, I conclude my session, and what I tried to look upon was the basics of orthodontic tooth movement and orthodontic tooth movement in periodontally compromised patients with some case examples, and basic aspects of frenectomy, when and what are the contents of frenum, and how to retain, etc. And finally, a basic aspect of accelerated orthodontics. So friends, together we achieve more is the expansion for the word team. My call is, let us integrate or bond for the benefit of our patient. Hence, together we can deliver more to our patient. for their best results. And my sincere thanks to Dr. Baiju RM, Professor of Periodontics, GDC Kottayam, for his magnanimity in sharing the surgical pictures. And I thank you once again for your patient hearing.
Yeah. Thank you. Hello.
Thank you, sir. Thank you, sir.
Yeah,
Am I audible?
yeah.
Am I audible, sir?
Yes. Very good. Now I'm not able to see if there are any questions that are actually posted. I don't seem to be finding many. Dr. Gautami, am I missing out something?
No, sir. Sir, we'll have it once the second session also gets over. I think by the time you'll have more.
Okay, fine.
We'll do it at a time. That would be a better idea, sir.
Okay. Then.
Yes, sir. Now the session will be continued by Dr. Ravi Kiran, which would be moderated by Dr. Padma Priya CV, who is an orthodontist and a dean for student and support services of Vishnu Dental College.
Good morning, everyone. I'm privileged to introduce Dr. Padma Priya ma'am. Dr. Padma Priya, presently working as professor and head in Vishnu Dental College, Bhimavaram. She has completed her graduation from HKES Dental College, Gulbarga in 1997. Later, she completed her master's from College of Dentistry, Dental Surgery, Manipal in 2000. She worked as an assistant professor in Manipal for 3 years. And she joined at Vishnu Dental College and has been a postgraduate teacher with a teaching experience of over 20 years and is the Associate Dean of Student Support Services and has been in active private practice for the past 18 years. She is an active member of the AP Orthodontic Study Group and currently the executive convener and also executive member of Indian Orthodontic Society for the past 3 terms. During her tenure as EC member, she has moderated and chaired many sessions like Innovation Conclave and webinars. She's invited as guest speaker at national and state conferences. She has a considerable amount of national and international publications to her credit. She has conducted numerous workshops at VDC such as Standard Edgewise Technique, Clinical Chronicle, and has been a resource person for many CDE programs at various colleges. Recently, she has also certified as in-house clear aligner provider. Over to you, ma'am.
Thank you, Gautami. Am I audible?
Yeah, you are audible.
Good morning, respected senior members and dear friends. Indeed, I'm privileged to be in this platform. Thank you, ILB. It's very nice to hear you again. I think last year we had your presentation. And I'm indeed privileged to introduce Dr. Ravi Kiran, currently working as Professor and Head Department of Periodontology, Darshan Dental College and Hospital, Udaipur. He did his undergraduation from VS Dental College and Hospital, Bangalore, and post-graduation from the same college. And presently he's working in Udaipur, Darshan Dental College, and he has a teaching experience of 14 years. Over to you, Dr. Ravi Kiran. And at this juncture, I would like to emphasize, I think there is a paradigm shift in the orthodontist view about the way the periodontists treat or how do we approach the orthodontist, because with the advent of adult orthodontics and adjunctive orthodontics, I think I cannot emphasize more on the periodontist role before orthodontic treatment, during and after orthodontic treatment. So we are very eager to listen to you, sir. And you, over to you. Over to your presentation.
Thank you, ma'am.
Good morning, everybody. Thank you, LB sir. That was an amazing presentation. You did go into necessary details and everything, putting foundation for my next presentations. Welcome you all, everybody, for the second edition of PERIO. So we'll go second edition of PERIO AKSHAYA. So now my part of the presentation will be about the periodontal aspect of ortho related patients. So I am Dr. Ravi Kiran. I work as a professor and HOD in the Department of Periodontology, Darshan Dental College, Udaipur. I am also the in charge for Implant Center in Darshan Dental College. Today's topics we'll be talking about in four main headings. So one heading which we'll be stressing about is periodontal considerations for orthodontic patients, and the second consideration what we're talking about is periodontal health a necessary prerequisite for orthodontic treatment. The third topic what we're going to talk about is periodontal problems. We're going to divide this into two. One of the major thing is going to be talking about gingival enlargement, and the second problem that we come across during orthodontic therapy is gingival phenotype issues. Coming to the first topic, what we're talking about is periodontal considerations for orthodontic patients. So we all know by now that the periodontal diseases is biofilm induced, and mainly the severity and extent is modified or affected by risk factors and host immune systems. Many recent classification stages this from 1 to 4, and then it gives a grading from 83 based upon the rate of progression. So what we need to understand is the stage 1 and 2 patients can be treated thoroughly and then transferred immediately towards orthodontic therapy without any problem as such. And the stage 3 and stage 4 is difficult to transfer to orthodontic therapy. The main reason being, whenever the stage 3 and stage 4 approaches, we have more of furcation involvements, that is their anchorage for your orthodontic therapy. The molars are getting involved, the interradicular as well as interdental bone are involved in this stage 3 and stage 4 as we progresses for the further stages. So it is not easy to directly transfer them from periodontitis patient to treated treated and then transferring it into orthodontic patients. So stage 1, stage 2 easily controllable, easily treatable, and there's no loss of anchorage for these molars, so it is easily transferred this thing. So we need to be cautious about transferring this stage 3 and stage 4 approach. So, and coming to the grading, grade A and grade B are quite easy to be controlled and can be reduced based upon taking care about the grade modifiers. Grade 3 we cannot put the patient on orthodontic therapy unless we change the grade back to grade A or grade B. So whenever we say the periodontal treatment has to be done, and what is the main plan or main success of this thing is a systematic plan to seize any of the grade modifiers, that is smoking and diabetes, and then initial periodontal therapy, and the corrective phase is where orthodontic therapy is going to come into, and we need to put the patient on supportive periodontal therapy. So we can always say what is the end point, or we say like clinically how do you say the treatment is done or cleared about this thing. So the main goals have been given for this thing is the clinically achievable goal what we need is required before we transfer the treated periodontitis patient to orthodontic therapy is reduction in full mouth bleeding on probing index, which should be less than 25% should be achieved, and the pocket should be less than 5 mm, which is maintainable pockets, and the control of furcation involvement of multi-rooted teeth that is not exceeding grade 1, and then absence of pain and the discomfort. This is the achievable clinical target which has to be achieved before we transfer the patient into orthodontic therapy. This definition usually coincides with our periodontal health defined in 2014 classification, or even the reduced periodontal health, whichever related to this thing. So now we are talking about transferring a periodontitis patient into orthodontic therapy, and we always have to see that the patient, we have put the patient on maintenance therapy. During this maintenance therapy, the orthodontic therapy is going to be happening during this procedures. So now periodontal therapy, active periodontal therapy is the part where we are aiming at controlling, eliminating or altering the etiologic factors and able to regenerate whatever it is required. So this part is active periodontal therapy, and then following which we put the patient on is going to be your maintenance therapy. So the point being stressing about the active active periodontal therapy is whenever the periodontitis is mild in nature or the patient is affected from mild periodontitis, the active periodontal therapy limits itself to non-surgical therapy alone. So that means to say a patient who is requiring only non-surgical therapy, and that is the end point of his periodontal therapy. So these patients, these type of patients have to wait for 3 to 6 months after the completion of periodontal therapy to start your orthodontic therapy. So we are going to talk about what the reasons are and all as we come across. So let's start with the time gap interval that is required for periodontal therapy, and then the time gap required before we start our orthodontic therapy. So the mild periodontitis affected patients whose end point of periodontal therapy or active periodontal therapy is non-surgical therapy. So these patients have to wait 3 to 6 months. And also making note throughout this period of evaluation, the grade modifiers and compliance to be kept into mind, and keep recording at regular intervals of time. So now the patients with moderate to severe, so or mild to moderate patients, periodontitis patients, we usually perform surgical therapy. So the patients who are requiring surgical therapy, non-regenerative, that is being the end point, these type of patients have to wait for 6 to 9 months for the end of periodontal therapy, and then followed by orthodontic therapy. And the patients we are having regenerative periodontitis, regenerative periodontics has been applied, or we have some amount of bone regeneration which is involved in your periodontal therapy. So these patients have to wait up to 8 to 12 months before the start of orthodontic therapy. So we are sure about, now we have active periodontal therapy and then supportive periodontal therapy. Now active periodontal therapy would be the end point would go to be the non-surgical for them 3 to 6 months. Then surgical periodontitis, surgical periodontal therapy with non-regenerative techniques that have been used, they have to wait for 6 to 9 months. And then surgical therapy we requiring regenerative endpoints are going to be, we require to wait for 8 to 12 months. So this is a time period required before we start, time period required for end of periodontal therapy and then the start of your orthodontic therapy. So where do we get this data or suggestions for this protocol is in the article PERIO in 2019. They gave a commentary about this thing, mentioning about the particular periodontal treatment requirement and then the time period gap required for the initiation of orthodontic tooth movement or orthodontic therapy. So now the whole point is we have a diseased periodontium, because we're talking about periodontitis patient requiring orthodontic therapy. So we have a diseased periodontium which need to be treatment. So different type of treatment: surgical, non-surgical, surgical regenerative, surgical non-regenerative therapy. So these patients has to be treated and the health has to be achieved back to the normal or reduced level, and then following which the orthodontic therapy has to be continued. Now, why this specific 3 months, 6 months, and then the 9 months and 1 year is, this is all coinciding with the tissues that we are talking about or the tissues that we are treating. So basically, when you're talking about non-surgical, we have maximum soft tissue healing and remodeling that has to happen during this period of time. So soft tissue coincides with 1 to 2 months of healing or maturation remodeling, following which orthodontic treatment can be done. Whenever we're talking about surgical periodontics, we have majority of soft tissue healing to some amount of remodeling that is happening in the bone as well because of the reflection of the flap and other things. So we need to have the bone that is going to be in a stable remodeling cycle before we start our orthodontic tooth movements. And when you talk about regenerative, why the 1 month is whenever we have used any graft, that is an artificial allograft or xenograft. Allograft, xenograft are artificial synthetic material. So this synthetic graft material has to get converted into new bone completely. So imagine the bone, the graft is converting in a mid stage, and then you start your orthodontic tooth movement. So orthodontic tooth movement itself again brings about bone formation and bone resorption. So this may enhance or deteriorate the regenerative potential or the activity that is going on. So we need to have the tooth movement on or around the tooth. The bone that should be there should be a new bone formed, which is in the remodeling cycle. So that's why the time period is 1 year. So this is a very good commentary which is based on a sound biological principles, which giving the rationale for this gap period between active periodontal therapy completion and then starting of orthodontic tooth movements. Now we talked about the periodontitis patients requiring orthodontic therapy. So now we come to the second class of patients, which is non-periodontitis patient requiring orthodontic therapy. Usually the teenagers which is not suffering or a healthy maintained therapy. So in those patients, they're all usually the teenage patients are all self-motivated for bracket placements, but they're not aware or they not have any idea about what is the importance of periodontal health, what is the periodontal health maintenance during this orthodontic therapy. So in these patients, what we can do is compliance is what has to be evaluated at each step and ensure that complete compliance is available from these patients. So what we can do is we can brace these patients and then wait for about 1 month before the activation of orthodontic forces. So in this period of time, we can motivate, evaluate the compliance, and once we ensure that compliance is at full efficiency, then we can use active orthodontic forces to be applied, and then starting with the other things. So other thing to be considered in these patients of non-periodontitis are growth spurts, puberty, hormonal variation, which again affects the expression of the gingiva during this period of time. The second part of the presentation is periodontal health. That means to say orthodontic therapy can be done in any time period of time, or periodontal health to be achieved as a prerequisite for this thing. So let's see what is health. Health is nothing but is dynamic in nature. That means to say we have modeling and remodeling which is happening. That means to say there is bone formation, soft tissue formation, soft tissue remodeling, which is going to be changing of older tissues into newer tissues. So that means to say there's a overall both mechanisms at play. What is formation? One is destruction, which is happening. But overall, when you see as a tissue volume, there is no reduction in the tissue volume, or there may be increase in the tissue volume if at all we consider any growth phase related to this thing. So health is something which is dynamic in nature, where both the processes are active, that is formation phase and then destructive phase also. But overall we are going to have tissue volume is not reduced, maintained or increased depending upon the growth phase where you are going to interfere with this. So this is the physiologic limit within which the orthodontic forces are going to be playing. So orthodontic basically works on the principle of replacement bone deposition. So the tooth is moved. So the tooth is moved, and the tooth as it moves, it is going to resorb the bone in the direction of its tooth movement, and the bone is formed in the opposite direction from where it is moved. So orthodontic tooth movement happens by replacement bone deposition. So amount of bone that is lost is going to be equal to the amount of bone that is being formed into this thing. So for this to happen, we need to work under this physiologic limit where overall volume of the tissue is maintained. Okay, so this is beautifully explained by LB sir during his presentation in the initial stage. I don't have to go into detail about all this tension size or compression side and everything related to this thing. So now that is one part where we're going to talk about what is health. Now when we talk about periodontal disease, the mechanism by which it is going to act, and the orthodontics, that is going to mechanism by which is it. So host and bacterial mediators stimulated, this is going to be affecting the target tissue, that is your periodontal ligament and alveolar bone. This will result in non-replacement bone resorption. So bone resorption, the cellular mechanism is the same that happens in your orthodontic also, but here we are talking about non-replacement bone loss that is happening, okay, in periodontal disease. Now whenever we talk about orthodontic therapy, again the mechanical strain in the bone, the forces that have been applied by the tooth is transferred to the bone, mechanical strain and stress, this is converted targeted by periodontal ligament and alveolar bone, and this is converted into cellular mechanism, which is replacement bone resorption and bone formation. Okay, so whenever we are talking about orthodontic therapy, we need to have only one mechanism at action, that the mechanism that we want to be playing at that site and the target tissues of periodontal ligament and alveolar bone is replacement bone resorption, where amount of bone resorbed and amount of bone formation is going to be equal and the volume is going to be maintained. So imagine doing orthodontic therapy in a diseased periodontal tissues. So we have one mechanism, bone formation and bone resorption, which is happening. At the same time, we are adding one more mechanism of bone resorption adding to this thing. So this will result in overall tissue loss, because two mechanism of bone destruction is at play and only one mechanism, that is your forces and regenerative thing, that is going to be acting after orthodontic. So it is safer to have only one mechanism at play to ensure predictable outcome which is easily controllable. That is your orthodontic forces. So hence the orthodontic therapy has to be done only on healthy tissues, because we want only one mechanism to be playing on this target tissue, that your periodontal ligament and alveolar bone. So this is the first part why we need to insist on having to do orthodontic therapy on healthy periodontium only. The second part why we want to have healthy periodontal tissue is whenever orthodontic forces are applied, these orthodontic forces are converted by periodontal ligament into tooth movement. That means to say the forces applied, resorption, bone formation, and then the movement of the tooth are going to occur based upon the forces, direction, magnitude, and related to this thing. So healthy periodontium is the only periodontium that can handle these forces thoroughly and effectively, which can transfer these applied forces into tooth movement. Imagine this periodontal ligament is diseased, so it is not going to handle this regular normal orthodontic forces effectively into this thing. So then it is going to result in uneven forces distribution. The same way the regular forces can be like inducing trauma or going to be heavy for this periodontal ligament. So again, the diseased periodontium will not be handling the regular orthodontic forces in a proper way and give the proper this thing. So healthy should be there present, because we want only one mechanism to be playing at bone formation and bone resorption. Second thing is, for proper and effective transformation of orthodontic forces into tooth movement, we need to have healthy periodontium. Sorry. These are the two mechanisms, two requirements by which we insist that orthodontic therapy should be always done by in a healthy periodontium. And the second point we need to mention about or stressed about is the health of the periodontal ligament is not just to be achieved pre-ortho or initial phase of ortho, but the health has to be maintained throughout the orthodontic therapy, because orthodontic forces have been applied throughout the progress, throughout the therapy. So periodontal health is not just a requirement, it is a prerequisite and it is a must for the starting at the start of orthodontic therapy, as well as maintain this health during the orthodontic therapy as well. So the next part of this thing is we'll talk about problems during orthodontic therapy. The most common problem that we're going to talk about or that we come across is our gingival enlargement. So usually orthodontic gingival enlargement is like proliferative in nature, usually fibrotic, not much of bleeding, but we see just gingival overgrowth or gingival excess. Many a times we relate this to inflammatory induced gingival enlargement, but when you see clinically, you don't see much of the inflammatory signs like change in color or change in anything. But yes, we can see some amount of fibrotic in nature, which is going to be like excess in excessive tissue covering the brackets, arch wire, or interdental papilla. Usually the interdental papilla that is going to be involved in this enlargement. However, there are two mechanisms we are going to be orthodontic therapy, the mechanical stress that is going to be induced in the bone, which is going to cause some amount of bone formation, bone resorption. This phenomenon we're going to talk about, the regional accelerated phenomenon. So does this regional accelerated phenomenon has any effect on proliferative nature of soft tissues in particular situations or particular cases? That is not yet been proven as such, but there is one this study which has been histological study which was done. So they say some amount of metabolic changes that is going to bring about at the local site, which usually influences the proliferative nature of the epithelium, but it is not yet been proven. So there is no particular stating mechanism which says that orthodontic therapy per se induces gingival overgrowth. However, most of the times we relate this to as inflammatory induced irritational gingival excess that is going to happen. So now when the excess happens, other confounding factors related to this thing are puberty, hormonal changes, thick phenotype, and oral hygiene status. So a note on thick phenotype is, so whenever the patient is having spacing and the patient is having thick phenotype, and when you get the two together, you are just compressing the fibrotic tissue to a smaller space. So it may look like gingival enlargement, but it may not be. So in either case, whatever the thick phenotype or any other gingival enlargement, the treatment is going to be gingivectomy and gingivoplasty. So before we attempt any of the gingivectomy or gingivoplasty, always ask the orthodontist for the stage which stage of orthodontic therapy, because we need to know about is active forces been applied during this stage or not. Okay, so now after this we are going to talk about when to do gingivectomy. Do we have to do it during the orthodontic therapy at any stage that is required, or we just have to wait till the end of this thing? Because there are two school of thought. So if orthodontic therapy or the oral hygiene maintenance is the reason for this gingival enlargement, even if you treat, it's going to recur again. So why do it and wait for the end of this thing? So I am going to give you two protocols or two points to evaluate why and when to do it. If the gingival enlargement is involving in functional aspect of orthodontic therapy and or excessive tissue is slowing down the tooth movement, or if it is interfering with bracket, band, placement or arch wire, this thing, you have to do the gingivectomy at that stage of orthodontic therapy. You don't have to wait till the end. You may have to do multiple times. Usually, rarely that happens, but yes, if it is functionally involved, if it is excessive tissue slowing the tooth movement and bracket and arch wire formation or placement is going to give any problem, or oral hygiene issues are involved, so you have to attempt the gingivectomy at that point of time. You don't have to finish the case like ideal aesthetics or anything related to this thing, but yes, majority of the gingivectomy can be done and we can make sure that it is not interfering with the tooth movement or bracket placement. So during that stage of orthodontic therapy, you can always initiate gingivectomy and gingivoplasty. So one consideration with this thing is, whenever you are planning for gingivectomy, you need to make sure that active orthodontic forces are not acting during that period of time. That means to say, for whatever the tooth movement has occurred, to hold the tooth position, remove the active forces and then hold the tooth in that same position, go for surgical this thing until the healing period for about a week time or 10 days. You don't have to apply active orthodontic forces during this period of healing. So the reason being, or the rationale being, this thing is active orthodontic forces induces mechanical stresses. This mechanical stresses induces mechanical stimulation, metabolic stimulation, which may result in growth of the gingival tissues again. So we need to just make sure that whenever you are attempting gingivectomy or gingivoplasty during orthodontic therapy, always ask the orthodontist what stage of orthodontic therapy it is going, and always make sure that no active forces are acting during this stage of surgical treatment that is going to be happening with this case. Okay, so now if at all the gingival enlargement is not interfering with aesthetics, it is not interfering with any of our orthodontic therapy brackets or anything, we just can wait till the end of orthodontic therapy and then we can do the gingivectomy or gingivoplasty at retention phase or after debonding. If it interferes with any of the orthodontic therapy, tooth movement, then you do it at that point of time. If it doesn't interfere, then you're going to do it at the end of orthodontic therapy. Now, what type of technique is going to be used? This thing is the regular gingivectomy techniques can be used: scalpel, electrocautery and laser. So whenever using cautery and laser, necessary precautions to be followed. So what is the personal preference? We always prefer scalpel over electrocautery and laser, the reason being the electrocautery again works with electricity. So now we have bands and brackets and arch wires and things related to this thing. So this conducts electricity. So it should be very carefully held with this thing, or need to be done very carefully, because touching any of the arch wire can cause burns throughout the oral cavity wherever it is going to conducting. So the area of metal conduction is going to be more. So electrocautery need to be used with extreme precaution. Coming to laser, again metal. Usually most of the orthodontic appliances are metal in nature, so they're reflective. So laser is, again, when you're doing laser in orthodontic therapy, the area of reflection is going to be more. So we need to be a little more extra cautious about all these things. Just to keep it simple, scalpel is preferred. So whenever we plan the surgery for these patients, we just ask the orthodontist to remove the arch wire during that period of surgery or for a day. That means to say, you start today, you get the arch wire removed, do the surgical procedure, we can put the arch wire back at the end of the surgery, or we can put it in the next day. So it's just a precaution to have this easier or better manipulation of the tissues and better access. Otherwise, it can be done with arch wire also. It is little difficult or time consuming, but you can always ask the orthodontist at the need. Let him take the call. Can he take out the arch wire or not? But you can as a orthodontist, you can always ask him once. So the third part is the phenotype issues related to during the orthodontic therapy. So gingival phenotype, let's just revise this. We know that everything is, everybody knows about this thing, just revise once. So periodontal phenotype has two components. One is gingival phenotype component of this and the bone component, bone morphotype into this thing. So gingival phenotype again has two points in this thing, that is gingival thickness and amount of keratinized tissue width. So we're not talking about attached gingiva, we are talking about keratinized tissue width. The second part of the phenotype is bone morphotype, and we have adapted that three types of phenotypes are available in the nature. That is going to be thin scalloped, thick scalloped, and thick flat, which is adapted from 2017 World Workshop for Classification. These are the few features. Whenever you're going for orthodontics, thick phenotype, we don't have to bother anything much, directly go to this thing. Thin, we need to be a little precautious, and we need to do some amount of pre-orthodontic evaluation so that we don't end up in any of our mucogingival problems during or later orthodontic therapy. So there is a beautiful study which was done about amount of width of keratinized gingiva, what are the changes that occurs during orthodontic therapy and its significant impact on the periodontal status. So the finding was, during orthodontic therapy there are areas which will increase keratinized tissue. So that is one of the finding, and this other finding that was in this study was a minimum of 2 mm width of keratinized tissue is capable of withstanding the orthodontic forces, regular orthodontic forces that is applied onto the tooth surface. And tooth lacking keratinized tissues before orthodontic therapy did not produce any new keratinized tissue. That means to say the keratinized tissue should always be present, which pre-orthodontic, which can get increased during orthodontic therapy or post-orthodontic therapy, but where the areas which did not have keratinized tissue did not show any new keratinized tissue formation. So orthodontic therapy doesn't induce or create any keratinized tissue. If it is present, it may increase. So that is the point that you need to keep into mind. So mucogingival problems noted after orthodontic therapy are often the result of pre-existing mucogingival problems. That means to say, pre-evaluation of orthodontic therapy is before orthodontic therapy is one of the crucial factors. So any of the initial mucogingival problems or predisposing sites which are present before orthodontic therapy is going to be highlighted or becomes a problem. So it's a most of the mucogingival problem can be eliminated with thorough evaluation before and treating them before orthodontic therapy as such. So this is the overall observations of this study, which states that keratinized tissue increases if it is present and minimum 2 mm is required, which can be able to withhold orthodontic therapy. Orthodontic therapy per se doesn't create any new keratinized tissue, and mucogingival problems are before present already. It's not the result of orthodontic therapy as such. So, and then we have tissue modification therapy and a meta-analysis which was done in 2019, which beautifully explains what happens if you do any of your phenotypic modifications during or after before orthodontic therapy. So this meta-analysis concluded that any of the hard tissue phenotype alteration that was done with advanced orthodontic therapy, that is your corticectomy assisted orthodontic therapy, which LB sir totally explained you detail about different mechanisms and this thing. Whenever the bone graft have been used with this thing, there was a good increase in the buccal cortical plate thickness. So we're talking about enhancing or phenotype modification, especially the hard tissue augmentation during orthodontic therapy. So that's what the meta-analysis says, that it did give good results. However, the number of studies that was included here was not adequate enough to draw a conclusion about soft tissue modification to be done during orthodontic therapy, before or later. So however, we have few protocols where to augment of this thing. It is not established protocol as of today, but there are many author recommendations. So if at all we come across any of the mucogingival problems related to soft tissue that is going to be there, it is always better to treat them before orthodontic therapy. So if at all any hard tissue augmentations, phenotype alterations to be required, and that can be done with advanced orthodontics, that is a corticectomy associated orthodontic therapy, always do hard tissue augmentation during orthodontic therapy. So this is the suggestion that has been given by author recommendations. However, I came across one of this study in IJPRD, so which classifies the type of phenotype and then suggest few treatment modalities, what type of treatment modality to be there. So it classifies the thick based upon the buccal cortical plate and the soft tissue loss which is going to be there as class 1 thin periodontal phenotype, wherein which the bone also is thin and the soft tissue is also thin. The class 2 is bony dehiscence, wherein which we have soft tissue present but there is loss of hard tissue or the buccal cortical plate. And then the class 3, wherein which you have gingival recession, nothing but your hard tissue and soft tissue loss which is going to be there in this, which is going to go for orthodontic therapy. So this suggested, so we are talking about what we are talking about is OPRO, orthodontic periodontal regenerative operation that has been required. So they suggested that whenever the class 1 it is indicated, so we can go for connective tissue alone and then hard tissue augmentation. So these two can be adequate enough to treat class 1 indications. And whenever the procedures 2, the procedure 2 includes hard tissue augmentation plus mucograft placement. And this can be done in class 1 and class 2 type of biotype. And then the third indication is hard tissue augmentation, then connective tissue as well as endogain, wherein which it's going to be for class 3 and class 2 and class 3. It is very easily mentioned here that you just put the hard tissue, put the soft tissue and this thing. When you see, whenever we're talking about class 3, here what we're going to talk about is we had gingival recession, that is loss of soft tissue which was there. Just to cover this regenerative techniques and everything like that, we need a coverage to be occurred. So it is clinically very challenging to achieve these things, which is just a suggestion that is going to be there, and this is based upon the case reports that they have done. So it's a good suggestion wherein which they talk about when there is only thickness which is going to be there, use connective tissue, and then whenever it is hard tissue and soft tissue loss is there, use hard tissue enhancement and then use mucograft, and then when hard tissue and soft tissue loss is there, you use connective tissue, endogain and hard tissue. It's clinically very challenging to achieve these results, or to perform, not even achieve, to perform this result itself, it is going to be very tough. So these are the three, these are the topic that we are going to be discussed about the phenotypic alterations. Now, what are the take home points or concluding points are: periodontal health is a necessary prerequisite. It is a must before any orthodontic therapy. Stable and sufficient mucogingival unit, if it is present preoperatively, evaluated, and if it is present, it will eliminate most of the post-orthodontic mucogingival issues. If at all any problems has been associated with mucogingival soft tissue related, you always perform, finish and prepare the periodontium and then make it undergo orthodontic therapy. And any hard tissue alteration that is to be required has to be done along with advanced orthodontic therapy. Now we need to keep in mind that periodontium and alveolar bone is the target tissue for both orthodontic and periodontal therapy. So both therapy must support each other and keep updated at regular intervals for early negotiation of problems in the initial stage itself. So always keep in mind, orthodontic patient is a periodontal patient on maintenance. He is undergoing orthodontic therapy, but you still have your maintenance protocol. So you need to see the patient at regular intervals of time. So by saying this, I like to conclude my presentation. Thank you, Vishnu Dental College, and thank you, Gautam Man and the entire team for giving this opportunity. Now the floor is open for question and answers and discussions.
Thank you, Dr. Ravikiran and Dr. LB. I think both of you have covered the most important points, which I think the orthodontist would like to know. The take-home points of your presentations are very good, Dr. Ravikiran. And I have there are few questions in the chat box. First, I would like to ask, and then we would discuss. When gingival recession should be treated if it occurs during orthodontic treatment, during or after orthodontic treatment? This question is for you, Dr. Ravikiran. Gingival recession, if it is treated, if it occurs during orthodontic treatment, what would you do? Whether it is done during or after orthodontic treatment? Dr. Ravi Kiran, you are not audible. Can you unmute?
Is it audible, ma'am, now?
Yes. You are audible now.
Yes, ma'am. First thing is gingival recession should not happen during orthodontic treatment because we are emphasizing on eliminating the problem before it occurs. So pre-operative evaluation is a must. And if you feel that the mucogingival junction or the mucogingival unit is somewhere compromised, we need to treat it before orthodontic therapy because we want a healthy periodontium and healthy soft tissues around the tooth for that movement to happen. For some reason, if at all, this is the prerequisite, so it should not be happening. For some reason, we ignore and we missed out during the treatment plan, and we see that the mucogingival problem is going to be enhanced during the orthodontic therapy. Then we need to take care into consideration two things. Is the active orthodontic therapy phase is over or not? If that phase is over, then we can go ahead with the gingival recession treatment. If not, then we need to wait till the end of orthodontic therapy. That is one thing. But if you think that the recession is going to get worse during the period and the leftover period of orthodontic, then we need to slow down the orthodontic therapy, stabilize the mucogingival unit, and then continue. Once it is stabilized, healed everything properly, then we need to continue with the orthodontic therapy. So it is depending upon, is it going to be a progressive recession during the orthodontic therapy, or it is just the expression and it stops there. So if it stops, then we need to approach it in the end. If it is a progressive type, then we need to reduce or slow down the orthodontic therapy and then treat the mucogingival unit and then continue with the orthodontic therapy. I think Rekha ma'am, I answered your question.
Sir, here I would like to add a point. I think before even actually starting the case with orthodontic treatment, what we need to check is the width of the attached gingiva.
Yes, ma'am.
And then the new normal for orthodontists nowadays is non-extraction. So inherently, I think we are expanding the arches. We are throwing the teeth forward, and thereby, I think we are causing the gingival recession also. So I think as orthodontists, we need to plan a case properly to avoid the gingival recession to some extent.
Yes, ma'am. Means as that one of the studies which mentioned minimum 2 mm of keratinous tissue should be present. At the same time, we need to make sure that the phenotype is medium to thick. Thin phenotype, when we expand the arch, it is definitely go for recession. So we need to do phenotypic modifications prior to ortho so that we are going to have stable periodontium during the orthodontic therapy. So stable periodontium that is healthy, at the same time, adequate quantity of the soft tissue should be present before orthodontic therapy and during orthodontic therapy.
And I have a question for you, LB. Role of orthodontic movement on osseous defect.
Am I audible, Doctor?
Yeah. LB, you're audible.
Yeah. What was the question?
Role of orthodontic movement on osseous defects. That means
Yeah.
I'm assuming that the osseous defects are already present.
Yeah, with orthodontic treatment, we can move the tooth in any direction. Actually, tooth movement can be undertaken occlusally or mesially or distally, depending on the force that we apply. So suppose if you are extruding the tooth, we can move the tooth out of the socket. Maybe if it is after regenerative therapy, probably it can enhance the bone fill or the acceptance of the bone, I suppose. And if we can extrude the tooth, we can reduce the defect by enhancing the bone fill. That's what I suppose. Ravi Kiran sir, can you update that?
I think it is the horizontal bone defects and the vertical bone defects and the tooth movement. Like we can reduce the horizontal bone defects if we include. I think that is what they want to know. Yeah.
Yes.
Just adding to the point, I think they have mentioned defect 2D essay. That means like 2 all defects, I think. I think that's what they wanted to ask as such. So one thing we need to understand here is orthodontic tooth movement happens because of the periodontal attachment to the bone. So when we are saying about osseous defects, that means to say there is portion of the tooth which is devoid of this periodontal ligament, which is in direct contact with the soft tissues. So now we need to quantitatively evaluate that the remaining root surface that is in close contact and having periodontal ligament attached to the bone should be always greater than the defect area which is not in contact with the so periodontal ligament. So only then the movement of this tooth will carry the alveolar process along with it and get treated with the defect. We cannot have a circumferential defect and only the palatal root is attached to it, and then we are going to move or create any osseous treatment. No, it will not happen. So we need to understand the root attachment, that is the tooth surface area interacting with the bone. The total surface area should be always bigger than the defect area which is exposed with the soft tissues. So only then any type of movement is going to be happening. If the osseous defect area side, the tooth that is devoid of attachment to the bone is more, then it is almost near to impossible. That can be. I think this should easier to understand which defect can be restored or which defect cannot be restored. So just take into consideration the quantitative aspect, surface area, total root surface area in interacting with the bone, and total surface area of the defect. So if the bone is greater, then it's going to be easier. If it is equal 50-50, it is a little tough. And if it is less than that, it's going to be almost near to impossible. I think this should answer. Anurag, I think this clears your doubt.
Thank you, Dr. Ravikar. Thank you for a wonderful answer.
Yes. And I think Rekha ma'am has also asked about role of growth factors in orthodontic treatment.
Yes.
I think, ma'am, the orthodontic tooth movement itself is happening in a healthy periodontium, and it is well within the physiological limit. So I think everything is in balance as of now. So increasing the growth factors will not fasten the orthodontics or better results. I don't think it has much of the role to be there. So growth factors can come into picture if there is any deficiency, or when we see that this area is going to be like some deficiency, should be augmented or supported. So orthodontic therapy is done in health, and it doesn't require any of the augmentation or support to be carried out for this thing. So I think it is very limited role with respect to movements.
Yeah, Dr. Ravikiran, actually quite a bit of research is happening related to the same. That's why I asked, posed this question, wherein they are injecting growth factors, wherein they're injecting PRP and all that, and then they are saying that the movement is accelerated by injecting this. So that is the reason I asked this question.
When we see the biological principles, there is by increasing the growth factors, tooth movement still again has to be the same amount of bone through which it has to travel. So if at all it is accelerating, that means to say the growth factors are resorbing the bone faster. So which you don't want.
Yeah.
So and orthodontic is always done under physiological limit. So I don't think it would won't have any of this thing. Yeah, in advanced orthodontics where corticectomy and all is done, maybe there it can have a role to play. But normal orthodontics, I feel it is limited.
Okay, thank you.
Sir, one point, can I supplement to that, sir?
Yes.
Sir, there has been a systematic review, in fact, published recently in Orthodontics and Craniofacial Research in 2021, where they have found out that this fibroblast growth factor and epidermal growth factor has been found to enhance tooth movement to some extent, sir. So, as Madam has pointed out rightly, studies are going in that direction, and it is coming up.
Okay.
So one more point to be added, the thickness of the phenotype can also be increased if we are, as ma'am has said, like microdermal pen and this PRF, if we injected IPRF, the thickness of the tissue can be increased. So we can plan it that way. This is the recent approach that we can take up. It's a point to be added. And growth factors will not enhance the resorption as such. They will increase accelerate the process as such. So we are taking up the case, and a thesis is also going on. We are working on that, and we have seen good results in that.
Okay. Thank you, ma'am.
Yeah, Dr. Vinita, can you just emphasize on how are you increasing the thickness? Because I think that would be more relevant, especially in orthodontic cases.
Ma'am, in case of thin phenotype, if we are using IPRF, injectable PRF, so before we start the treatment in the passive phase of orthodontic, or before the treatment, we can plan up and assessing the thickness of the gingiva, we can take up and treat it priorly, and then we can start for the orthodontic treatment. Ma'am, IPRF we are using.
Okay.
Ma'am, I'll share the article
Yeah,
with you
sure.
if you want.
Sure,
Yes,
sure.
ma'am. Surely, ma'am.
Please, if you can share to Dr.
And I
Gautami
can
and
share
we
my
will get.
cases also, ma'am. Yes,
Yeah,
Ma'am,
yeah.
you are injecting onto the site or micro needling?
Sir, we have tried with microneedling also and with IPRF site injections also.
Okay. Thank you, ma'am.
So we have another question. Can distraction osteogenesis be effectively used for implant site preparation?
Depends. If a single implant that is going to be there, so the distraction osteogenesis, you need to have cuts, and the movement of this thing is to be difficult. So when there's a full mouth, full arch or segmental, this thing is there. Yes, it can be used for site development. Single small areas doing distraction osteogenesis, mainly coronal distraction is been tried, but it's a little tough. So segmental can be used, and full mouth is going to be there. That can be used for distraction osteogenesis, can be used for site development.
It has also been used in cases with the primary eruption failure, where they induce the cut and extrude the tooth to the occlusion.
It can be used.
It can be done, sir.
It can.
Yes, sir.
Sir, Dr. Arun, KV Arun, sir,
Yes.
can I ask you a question? Sir, we have a question here. Is planned post extrusion of a fractured tooth where implant is planned a good treatment modality, or extraction and grafting is preferable? Further, what are the criteria for case selection in such cases?
I think we should ask the presenter the question, no?
So definitely, as you extrude, bone will form. As we extrude the tooth, bone would be forming. So that would be better. But any other insights?
We can ask Dr. LB and Dr. Ravikran for their views. I think then we can get back to this, perhaps.
Yes.
One thing is, Dr. Padma, I think when we are extruding the tooth and planning for a crown buildup, we should think of the long-term stability of the tooth in terms of its crown root ratio. As mentioned, I think yesterday, even though Andy's law may not be very valid, at least 1:1 crown root ratio we should maintain for its longevity, I suppose.
Yes.
Yes, that is true.
Yes. Yes.
So I think the question is, should we use extrusion or we should extract and regenerate? Which is preferred method and how do you select? I think in this thing, say about if at all the patient is going for immediate implant. I think Padma Kumar TP, you can mute the mic. I think one of the delegate, Padma Kumar, I think you can mute the mic, please. Yeah, thank you. So when to extrude and when to extract and regenerate. So now we need to see the site. Once we remove the teeth, if it is going for immediate implant placement or you're going to go for late placement. So how much of vertical defect or horizontal defect it is going to give rise to. Because extrusion will have some amount of limitations, regeneration will have some amount of regeneration. Like extrusion can get up to 2 to 3 or 4 millimeters of alveolar bone, depending upon the time provided, depending upon the tooth that can be done, single rooted or multiple rooted, this thing. So it can be decided that whenever it is less invasive, the patient is going to be wanting to be having less invasive. So you just go for extrusion, followed by very nominal augmentation that is required, then followed by implant. So if the fracture is up to the middle 1/3, so much of extrusion will take long period of time. So in those cases, partial extrusion plus regeneration can be used as a combination. It basically depends upon the defect and amount of augmentation that will be required for that implant site. Either it can be independent or it can be used as a combination, which can be used.
Yeah. So another question that has been asked, does addition of chlorhexidine to the bracket bring down the incidence of gingival enlargement?
Sir?
Does addition of chlorhexidine reduce the incidence of gingival enlargement during orthodontic therapy?
Yes, sir. If the
question, Dr. Rekharani has asked this question.
Okay. So basically, enlargement during orthodontic therapy is because of two reasons. So one is it is not proven yet that orthodontic therapy itself, the tooth movement, the regional accelerated phenomenon that is happening in the tissues, that will have some proliferative effect, epithelial proliferative effect on the soft tissues, but it is not proven yet. So that is one concept giving rise for enlargement. The second thing that can give rise to enlargement is inflammatory enlargement because of oral hygiene status. So wherever the enlargement is because of oral hygiene maintenance, yes, it can reduce, but it need not have to be put on a prophylactic method. So whenever we see that patient is not going to be compliant and that is going to result in inflammatory enlargement, then we can have a little bit of effect. But it's not a prophylactic that you need to put every patient onto chlorhexidine. So as such, if it is related to oral hygiene matters, then putting on chlorhexidine will give benefit.
Thank you, sir. Thank you for that answer from PERIO point of view, sir. But from ortho side, one point I wanted to highlight is that chlorhexidine coated brackets have shown a poor bond strength in attaching to the tooth, sir.
Okay. So prophylactically, it is negative. So for proper bonding, you should not be using any chlorhexidine before.
Chlorhexidine pre-coated brackets have shown to have inferior bond strength compared to other normal adhesives, sir.
Okay. Noted, sir. Important point. We'll make a note of this.
So I have a question for Dr. LB. What about the biomechanics of these aligners? What is its effect on the periodontium?
Yes, sir. That is a very important question and currently the hot topic, sir.
Yes.
Definitely aligner will be any day better in terms of periodontal health because it is removable. That is the main thing, sir. And the patient can resort to hygiene meticulously when the appliance can be removed. But the flip side is that patient has to wear the appliance full time. Almost 22 hours the patient is wearing the appliance. So studies have shown that periodontal health is in fact better. From periodontal side, the health is found better with clear aligners, and evidences also have shown that it is better for periodontal health.
But how about the force generated?
If I have to add, Dr. Arun, this is Dr. Anand speaking.
Yeah.
Actually, it's a very important question what you have posed. And the regular mechanotherapy, the fixed mechanotherapy, as you are aware that, the brackets are placed and the wire is inserted. So the amount of tooth movement is uncontrolled. Yes. Going to be some amount of favorable tooth movement and some amount of unfavorable tooth movements happening because there is exactly the amount of force applied is not in the hand. It's basically the wire which is going to do. Yes. Whereas in aligner therapy, what happens is the amount of tooth movement is dictated when you create your aligners. Whether you want 0.2 millimeters or whether you want 0.3 millimeters or whether you want 0.1 millimeter of tooth movement or you want some amount of rotation. All the movements are sort of controlled and you can dictate the amount of tooth movement which can happen in aligners. Hence, I would, according to me, or probably the literature also says that the forces are much more gentler in aligners compared to the fixed mechanotherapy. I hope that answers your question.
Hello. Arun?
Yes.
Can you hear?
Yes, sir.
Good morning.
Good morning.
So, regarding the aligners, what I asked about this, nowadays aligners is getting a supreme treatment point of view for orthodontic treatment. But now my question is, lot of cases are coming to us. They are stripping the areas and losing the contact points. Actually, periodontal point of view, contact points are very, very important. They are not looking into at all. They are just flattening on the proximal areas, getting the space and aligning it. Later, a lot of problems are come for the interdental area destruction. So what is your opinion?
We are asking this to the orthodontist, no?
Yes, sir. Sir, that's a very, very, very important and pertinent question, sir. Because aligner mostly work by arch expansion and tooth material reduction to create space rather than extraction, because extraction treatment with aligner has not come to in a great way. The control is not so great. So that is why the space gaining aspect is being undertaken by interproximal stripping. But interproximal stripping the articles say that if it is very correctly performed with meticulously done, probably the contact point can be maintained or the contact area can be regained. But again, if as you said, rightly pointed out, there will be a periodontal effect because of loss of or altering the contact point. Maybe we are altering to a the vertical height of contact point may be altered with the interproximal stripping. I hope Dr. Padmapriya can supplement a little bit to that.
Yes, sir. I think very pertinent question as of now. But we are using smoothening burrs and reducing the roughened surfaces. That is one thing. The second thing is the contact point is made into a contact area. So is that good? Is that okay to do it? Since that would also help us in retaining the correction. So that is what is happening as of now. So when we are doing the IPR.
No, what my point is that that is natural process, natural contact. But after flattening it, we are getting flat contact. That is not acceptable for the normal physiological contact point. So that's what I am asking about, because a lot of cases are coming nowadays just making a stripping on the without adapting the proper method of stripping. They just use burrs, and there are methods what AB was telling. If you are doing properly, okay. But nowadays, I don't think so. They are using that technique.
Sir, IPR has to be refined and properly has to be done. Definitely, the point contact will be lost, but there will be a increased area of contact. Contact area will increase. And if it is properly done, I don't think we would see any proximal caries. And that has to be done properly, as you said, sir.
Yes, sir. It is a pertinent area which requires further research, I think, Dr. Padma. Sir has pointed out a right area which requires long-term research to see the periodontal health following IPR and clear aligner therapy.
So actually we are creating the point to an area and we are intruding the biological width that we are enhancing, we are giving a chance for the interdental bone loss. We are actually initiating a disease over there, sir. A point is being created to an area and then it has been, so the patient has to be educated to maintain that thing, sir. And that information has to be passed to that patient also. And this is my point, sir. That is a limitation of that thing, sir.
Yeah, most of the times, Dr. Vinita, what happens is nowadays we get a lot of adult patients with a deep curve speak. Okay, the overjet is increased and the lower anteriors, there's a lot of gingival recession because the lower teeth are touching the upper palatal surface. So we need to intrude them. So as we intrude, definitely we are giving some amount of bone loss. So maintenance of periodontal tissues or the attachment is I cannot emphasize enough because most of these cases are adult cases, and since they want the treatment, they would have to go for
ma'am, for adult orthodontics, I agree, ma'am. But in my routine, what cases I have been seeing, some cases they are trying in the younger generations also. So that is like for thesis basis or doing something new. Students are attempting that, ma'am, and I have seen that. So it should be limited and it should be guided properly.
Yeah, definitely.
Usually we don't. It is fine. We intrude that area, but initiating a disease unknowingly, it's something like not ethical.
Yeah, definitely. We would not encourage that at all, Dr. Vinita. But intrusion in some cases has to be done because of the to level the curve of speed and to correct the malocclusion. But with proper, I think with proper guidance from the periodontist, I think we can reduce the mishaps or whatever is happening to the periodontal tissues.
Totally agree, ma'am. Yes.
Sir,
I have one follow-up question to this, the one which I asked before. So what is the long-term prognosis of this aligner? How long do you have studies of what the periodontium is looking like after aligner therapy?
Sir, I think the cases have started in 2010. Invisalign started, then in-house aligners have started recently. Since the forces are less, it should not be different from the fixed orthodontic therapy much. And the root movement also is comparatively less compared to the regular fixed orthodontic treatment in aligners. So the disadvantages of the fixed ortho also should not be there with aligners. That is what I'm assuming, since you cannot move much of root movement with aligners. So it is usually the simple cases we are doing with aligners and distalization cases. And extraction cases, to some extent, they have started. So definitely, I think we need to wait more, sir, for some light on this aspect. But aligners, I definitely would be advised for periodontally compromised patients and adult patients because of the oral hygiene issues.
I don't know, but in Chennai, where I'm situated, I find these people are they are placing aligners not just for simple cases. Complex cases are being taken up, under extraction cases are being taken up. They are not for adult patients alone anymore. They are treating all children with aligners only. So how much long-term prognosis do we have?
Sir, maybe only once you have a relapse or we see the finished cases, we can tell, sir. Because as of now, we just started here.
Yes.
And
aligners is even in the right now also it is in the incipient stage, sir. So in the infancy is just getting
Yes.
it is not at cross, but they have even complex cases, including orthognathic surgery cases, have been treated with aligners, and case reports are there, sir. So aligner is something which we cannot totally deny, and with the improvement of the artificial intelligence that they are using, it will percolate much down, sir. And there is something called Invisalign Teen, which Padma Priya knows that can be used for even growth modification treatments and things like that. So it is like, it is coming as a big way to replace the entire fixed appliance therapy, not on certain cases also in future, sir.
sir, and also the extraction cases, we need to use stats, sir. Accessory devices have to be used, either temporary anchorage devices like the implants or IZCs, the screws, mini screws or mini implants have to be used. So I think then you can have a better root movement with aligners.
Okay, there is another question being asked here. The point of crown root ratio being raised, I'm asking a question based on it. How important is the maintenance of crown root ratio while placing short implants? Perhaps this is an answer question for the periodontist, perhaps.
Hello.
Now we are talking about short implants. So then we come, Anusha. Coming to the short implants, usually we're talking about less than 8 mm in length. So these implants can be used only when we have adequate diameter to it. So we are talking about total implant surface area that is covered by the bone. So either we can increase this surface area by increasing the length, or we can increase this by increasing the diameter of the implant. So like 6 mm or 7 mm implants, which can be used as a shorter diameter implants, and then short length of about 6 mm. So they say 1:1.25 or 1:1.5 should be good enough. But there's no long-term studies proving this is the ideal thing or anything, but they do compensate for this thing. So for example, 6 mm implant length with 6 mm diameter can take up to the molar replacement that can be used. So that's what the literature says, but there's no clear-cut definition that 1:2 or 1:1.5 has to be the crown root ratio.
Okay, I have one more question for the orthodontist. This periodontally accelerated orthodontic movement, does it actually accelerate the total treatment time, or is it only the initial tooth movement that is faster?
Sir, periodontally accelerated orthodontic treatment can reduce the treatment time, and there are various methods applied. Periodontally, you are asking about PAO, means definitely it is going to accelerate tooth movement. So there are various methods of accelerating tooth movement and reducing orthodontic to treatment time, which are broadly classified as surgical means and non-surgical means.
Non-surgical means include oscillations or low level low oscillations and photobiomodulations and things like that, which has not been, which is not, there is no evidence that it really reduces the treatment time. Whereas this accelerated orthodontics by
you can talk about tell about RAP and MOP.
Yeah, right. So that's it. Surgical means where there is regional acceleratory phenomenon using micro osteoperforations or selective alveolar decortications have definitely shown to induce cytokine release, and induced osteoclast formation has been enhanced, leading to a rapid tooth movement. That is been identified, and evidence is there for that.
Actually, I was talking about the non-surgical methods because, I find there are many applications. I'm not wanting to name the products and all that, where the application is made outside the gingiva. And then they are saying this will induce tooth movement better and all that. So because tooth movement is based on the periodontal ligament, not the gingiva. So I don't see how it is that you can penetrate through the periodontium, affect the bone, and then affect tooth movement.
Exactly. Very good point, sir. That is actually, they call it as key opinion leaders or marketing things. There is something called a snake oil salesman. So that is, evidence has not shown, sir. Cochrane systematic reviews have shown that the non-surgical method have not really accelerated, no significant reduction in orthodontic tooth movement, sir.
I just wanted to add one more thing, because whatever may be, you wanted to have a tooth movement. That's our ultimate aim, isn't it? So we are mechanically you can do it, but now chemically, what is the possible that what is it right to say? We are inducing the inflammation there. Yet inducing the inflammation there, what is right to say? Cytokines. So what is the role of cytokines? That's why there are more and more research is going on, how effectively you can increase the tooth mobility by using the extra application of the inducing inflammation to be there.
Sir, injections of prostaglandin E2 have been attempted to periodontal ligament, which has found that it brings about statistically significant increase in tooth movement. But one problem was prostaglandin injection was very painful. But later there is one study which prostaglandin has been mixed with local anesthetic, and the injection has been performed. But even in human trial has also been done, which has shown. But it is again not very very popularly performed. Similarly, growth hormones, growth factors, as I said before, TNF alpha as well as epidermal growth factors have been shown to increase, local application has found to increase tooth movement. Dr. Padma, can you supplement on to that?
Regarding, I didn't get.
Growth factor.
Sir, growth factor induced tooth movement?
Yes, that's what he was talking about.
Okay.
Growth factors have been found to accelerate tooth movement.
Yes, sir, definitely there are studies stating that the growth factor induced tooth movements, but we have not done any here. I could only quote the references. But one thing I would like to mention here regarding not the molecular level, but in the biomechanical level, I would like to add the recent material Graphite TC85. It says it has the shape memory. So this also would induce consistent tooth movement. So again, I think this would play a role in periodontally compromised patients. Again, there are no studies about it, and this is a recently introduced resin material. I can tell about that if anyone is we just started using that material. So unless we finish the cases, I cannot emphasize on the consistency in periodontally compromised.
Ma'am, I'd like to add one thing. In cortectomy, ma'am, we are targeting at the 3rd or the 4th week of activation time. There, that time, if we are doing it, we are accelerating the whole process. And so is with the growth factors, we creating an environment. It's like a catalyst where we are enhancing the growth factors, whether it is PG2 or any other growth factor. We're kind of putting a catalyst in the whole process and just initiating the whole process that's going to take time. We are just reducing the time and that activation is there. So enhancing
Is
the
it in
whole process.
animals or human beings?
Ma'am, as such articles, we are at present when we are doing cortically, ma'am, we are doing in humans also.
Humans also. Okay.
So I'll just add a note of caution on this. Now 30, 40 years of periodontal regeneration experience has taught us that use of growth factors or cytokines is very dependent on two to three things. One, what is the dose? Two, how long is the release kinetics and things like this. So there is very little good biology. Because you know what happens? The role of all cytokines tend to be redundant and pleiotropic. That means the action of one cytokine is not just on one cell, it acts on many cells. And the role of one cytokine can be taken up by another cytokine. That is pleiotropism. So by just interfering with one mechanism that goes on in the total field of inflammation, how much of improvement you can get is not very clear. But however, what our literature says is it can jumpstart. The literature always says it is going to jumpstart a cascade of events. So you will get a start. After that, the longevity is maintained by your regular biomechanics and regular therapy, I guess.
So acceleration, sir.
Yes, it can jumpstart the sequence of events. So it doesn't sustain it fully. It can only jumpstart the sequence. So if this jumpstart is going to be sustained or not is dependent on the rest of your biomechanics.
No, sir, it's a jump start, but sir, we are initiating the process that is going to take a 2 or 3 months period. If we are initiating and escalating it, or if we are shortening the whole process of 1.5
but
years,
see, if whatever growth factor you are giving, how long does it get released into the environment?
Sir, it is IPRF and it is from that
No,
person
but
itself,
even if it is IPRF, you will liberate the growth factor for a period of 1 to 2 weeks maximum, not more.
Sir, that is also enough for the patient. If it's like slowing that, if we are putting 1.5 years of that patient to 1 year at least, so it is quite a good advantage. Sir. It depends on the patient and the clinician, sir, and the
no. But
see,
I am not saying there is no difference. The thing is, you are looking at jump-starting the cascade of events. That's all. It is not sustained tooth movement throughout the phase of orthodontics. It is jump-starting at one point. Then the treatment has to be sustained by your other biomechanical principles only.
Sir, only the initial stage only requires a lot of time, sir. After that, it is the movement that continues, sir.
I just wanted to add one more here.
Yeah.
We are asking about the application of the growth factors. But what is rightly said that we don't know how far it has been applied, how long it will be retained there, how much molecule you should, where to apply, because the whole joy you have been treating it. You not apply it one area. We have to apply it whole area. But what is now, I think it is that endogenous regeneration of the growth factors is most important. How we can induce endogenously so that can be applied all over. Otherwise, just applying one area growth factor, I don't think so it is going to be act on that.
Sir, I think for that reason only we are giving the micro-osteoperforations to induce the collection of the growth factors at that injury site. Is that because we have done studies, but with minimal tooth acceleration, the results have come in the department. Whether it is a propel device or a modified propel device, where we just make injury to the gingiva and move the canine into that site. So the studies have been done.
No, that's what I told you. You are inducing the inflammation there.
Yes, sir.
Externally, you are inducing inflammation. And
yes,
we have been, some studies has been going on. What is the effect of the lasers, photodynamic theory? Species has been done. Whether it is successful or not, we don't know. But they are trying their best to see that how effectively we can reduce the time for the orthodontic treatment. That's our aim.
Yes, sir.
Yes, sir. And finally, one more thing, sir. When the treatment duration is of 18 months or 1.5 years, whether that reduction of 1 month, 2 months does that make a real difference is something which we need to probe into, sir.
Exactly.
Patient's point of view, when you start a treatment, patient first asks, how long we have to wear the appliances. That's the first question they are asking.
Yes,
We
sir.
cannot
Yes,
give a direction there, especially you know that age period, 18, 19 period, youngsters are coming, married problems are there. So always they say that how long we have to wear, how long we have to wear. So our aim is to actually how far we will be able to get a predictable result. That is our aim.
Exactly, sir. Exactly.
Time
Yeah,
matters, sir, for orthodontics.
Yeah, but to the orthodontics, at least, you know, your patients want treatment. I have seen this in many orthodontic clinics. Your patients are coming and asking for treatment. Our patients never want treatment.
True, sir.
That is the big difference.
True.
Sir, an orthodontist is a moving publicity. An orthodontic patient is a moving publicity, actually. They don't require any special publicity as such. They are lucky in that.
How can we make it in our field?
That's what, sir, I think we need to.
Sir, again, every orthodontist patient has to go to a periodontist before, during, and after. I think that says
at least, you know, we hope that you can insist on this. At least that way, perio practice can improve.
Yes, sir, exactly, sir, exactly. Well said. And sir, Nandakumar sir, I think periodontal disease is so sweet that it doesn't cause any harm, any pain, unless it is in the last stage. I think in that way, we are a little unfortunate. But then as periodontists, I think we all play a very vital role in diagnosing the disease at an early stage, and then because without which no other branches exist. That's what I firmly believe. But they are
Exactly,
lucky.
ma'am. Exactly, ma'am. That 0.2 to 0.3 millimeter structure is the bread and butter of orthodontics.
Yes, sir. Yes, sir.
The entire specialty, the entire specialty is built around that 0.2, 0.3 millimeter structure, and we should be grateful and thankful to you be preserving that for us, sir.
Yes, sir. They should be grateful for us, actually. Grateful to us.
Definitely,
Point well taken, Gautami, and thank you for this opportunity. And thank you, LB and Dr. Ravikiran, for joining here.
Pleasure, ma'am.
And platform is yours, Gautami.
Thank you.
One more thing I just wanted to add, because most of the people come for orthodontic treatment. When you look at the clinical point of view, it looks very beautiful. And I request the orthodontist to evaluate the periodontal structures. At least they should have a probing periodontal probes to see that what is the pocket depth, because clinically it is very good. They'll start tooth movement within maybe 2-3 weeks time. The whole teeth will be aligned properly because of the bone. There's no bone support was there, and especially when you have this bone is when you have the dehiscence and fenestrations. That's a very important this thing. They are not at all looking at all this bones architecture, and they just see the clinical point of view, then start doing orthodontia. They will get a good result, but ultimately, what is end result. That's what I just wanted to tell the orthodontist. Before start your treatment, take an OPG, probing pocket depth, refer to the periodontist, get a clearance from them, then start treatment. Scientifically evidence.
Exactly, sir. There is one editorial by Vincent Cockich, charting before starting. So that is to be technically followed, I think, sir.
Yes. Yes.
And I see almost 75 participants. Can you please give your views and thoughts? All of you are very welcome on this platform. Because 2 eminent orthodontists are there. 3 eminent orthodontists are there, including Dr. Anand, who is the director of our college. They'll be ready to answer your questions. Dr. Pauline, any take on that? Dr. Victor, sir, do you want to add anything?
Here, I would like to add a point, Gautami. Dr. Dwarkanath sir once came to the department and he gave a rap to us stating that why you don't have a periodontal probe. So very well taken, sir. You again reminded me, Dr. Dwarkanath sir. Definitely, we will follow your advice.
I think it's 5-6 years down the lane, sir has told, and still you haven't.
No, we have now. No, we have the periodontal probes.
Then it's good. Then it's good.
more than charting, if orthodontist would just assess if the gingiva is bleeding, it's an easier thing to do. Then you could perhaps then refer it to the periodontist and then ask them to have a more thorough assessment of the patient. That would be so significant to be able to prevent any untoward outcomes during orthodontic therapy. So a very basic work you can do is to just run the probe around just to see if there is bleeding gums. So
Yes, sir.
could be as simple as that.
Yes,
Yes,
sir.
sir. Exactly, sir. Thank you for that, sir.
I can see Dr. Prakash, a very dynamic practicing periodontist, both academically and practice-wise. He's very active. I think he would come a lot of cases. Can you throw light on that, Prakash?
Ma'am, I think it's been extensively discussed by Arun sir, ma'am, and no, I saw Nandakumar sir also coming in and putting up his points. Perfect thing. It's simple. I think before any ortho work is started, a perio evaluation is very important. Not but still, periodontium makes the difference about the tooth movement. So I stay with all of your discussions being very positive and healthy, and about the growth factors, role, and all the other aspects, absolutely well discussed. I think the point is put forth by the senior faculties there who are there, and I just completely go by whatever the discussion has happened till now. Thank you for the opportunity, ma'am.
Thank you, Dr. Prakash. Can we wind up the discussion or any more points from any of the active participants here? Please take this opportunity as the second session of PERIO AKSHAYA is coming to an end. Dr. Pauline, any take on that?
No, as rightly everybody has been pointing out, actually such an excellent deliberation has happened, and very nice to see interdisciplinary approach. I think that should be the take-home point, that whenever any kind of interdisciplinary work is being planned out, there should be a thorough consultation on both ends, an ortho and a perio nexus, as we have seen here, even in other departments when it is possible. And as Dr. Peters very clearly said, charting before starting is a wonderful take-home message. And simple signs of inflammation, if it can be detected, if the practicing orthodontist or any other interdisciplinary dentist has the eye to search for periodontal diseases, definitely the gingiva speak to us. With that in mind, and when the intent to build anything on a stronger foundation of gingiva is there, I'm sure we can see better treatment options. Excellent deliberations from Nandakumar sir, Dr. Ravi Kiran, Dr. Arun sir. Arun sir was so well talking about the molecular aspect and the blending, and which was so true. It can only start off a reaction, but what follows in the 1.5 years of orthodontics is left to a plethora of events in the oral cavity. So many factors playing a role there. I don't have anything to add on that, but definitely we have to go hand in hand with each other to make it a success.
Thank you, Pauline. I think Dr. Anand sir can give his final conclude if he's there, because we all respect orthodontists, and so let this discussion end with an orthodontist.
No, I think everyone has made a very clear point, Gautami, and I guess all of us have to take each other's specialties seriously and follow the guidelines. I think that is way to move ahead, and I think this particular deliberation was an excellent deliberation according to me. And Dr. Arun made a very valid point on how the growth factors actually kickstart the thing, but studies have not shown how long do they take. But I would also add to that, saying that the growth factors are not injected once. The growth factors have to be given a couple of times. And but I really enjoyed the deliberation which happened very openly between the orthodontic group and the periodontic group. And I think at Vishnu Dental College, I think we will make it mandatory to have a perio probe in all the departments, not ortho department alone. I think at my level, I think I can make it happen. I think with the department of periodontics, I think it is very important that it is not just undergrad stuff where you teach your undergraduates how to probe a gingiva and then you leave it at that point. I think we need to continue doing it at every stage of our dentistry. It could be any specialty. I guess that importance has to be given to periodontics. And as Dr. LB said, an orthodontist would survive only if we have that 0.2 or 0.3 millimeter tissue. And if not for that tissue, I think orthodontists would not have survived. And thank you for this great deliberation. And thank you, Dr. Nandkumar. You made very valid points with your senior, mature levels of thought process. I think today we are at a juncture where, especially when it comes to aligners, since it has become very popular, and orthodontists were the last people to get into aligners. At least we have realized that aligners will still exist in this category of mechanotherapy. I think we entered it very late, but I think orthodontists have a great role to make people understand that just by giving an aligner and just by doing a proximal stripping, we could achieve tooth movement. I think the point of having the right type of contact, the right way of doing a proximal stripping is very, very essential. And I think the point which was pointed out by Dr. Nandkumar, I really appreciate his senior and I would say mature thought process. And I'm sure all the orthodontists in this group, and I'm sure many more orthodontists would watch, and they would agree to the point that proximal stripping is something which is not done really well. Hence, I think it is very important that we give a lot of importance to it, especially with aligner mechanotherapy. And Dr. LB, it was an excellent answering to the points which have been raised by the periodontal colleagues. You did a great job. And thank you once again, Gautami. I think it was a great session the last 2 days. Thank you.
Thank you, sir. I think we'll proceed for the valedictory. Or any other questions from the forum? Okay. Dr. Arun sir is nodding his head. I think we can. I think sir is a little hurried up. Yes, sir. We'll just start up with the valedictory.
Madam, the take-home slogan may be, there is no ortho without perio.
Agreed, sir.
A very good afternoon to one and all. I'm Dr. Shravanti, third year postgraduate. I would like to extend a warm welcome to all the dignitaries of the valedictory event. Today is a day to be thankful and to be inspired. On behalf of Team PERIO, Vishnu Dental College, I would like to extend our sincere gratitude and appreciation to all the periodontal fraternity without whom this program wouldn't have been accomplished. We are delighted to have Dr. Nandakumar sir and Dr. Victor DJ sir as our guests of honor for the valedictory ceremony. I request Dr. Nandakumar sir to address the gathering.
A very good afternoon to everybody. I think now, anyway, we have to wind up now. This is a very sad thing. I would have been liking to prolong for a one full day itself, because it's a wonderful session what you have been selected all these 3 days. And especially, I'm thanking the Vishnu Dental College, especially Dr. Gautami, whom I know lasted almost 20 years back. when we arranged a program, PG convention in Trivandrum, I think still she is remembering the nostalgic memories of that function, isn't it?
Yes, sir. Yes, sir.
Anyway, congratulations to you and your entire team of periodontology who are working for last 2 days, and especially selecting the topics also very, very important. That is, you have taken 3 important topics to be discussed at the pertinent hour. That is on the periodontology versus implantology. That's a very, very good question. Still, a lot of debates has been going on whether we have to extract a tooth, put an implant, and whether regeneration is possible at the expected level, because research is going on, because molecular and cellular level research is going on. So I think we foresighted vision should be there. And I require all the postgraduate students take this issue. It is a lot of research can be done. I think no other specialty can involve such a research in this field, which is medicine. And another thing is plastic surgical procedure also there. And there are a lot of surgical procedures, especially aesthetic point of view. Considering about the plastic surgery, 2 aspects you have to cover. One is covering how to cover gingival recession. A lot of questions are raised. Another thing is how to increase the keratinized gingiva. This is very important for the other departments also. That is conservative department, in ortho department. Without keratinized gingiva, we cannot do any treatment plan. And lastly, very interesting, ortho-perio relationship. We have been discussing very long. Without perio, ortho cannot be surveyed. Ortho also is required for our predictability of the treatment plan. And a very interesting topic has been selected. Congratulations to Gautami for taking these 3 very, very important topics to be taken. And I think that this is this can be continued in future also, selecting the topics. I feel that one thing you can add is interaction between the postgraduate students also. There's some topic can be given to postgraduate, what level they are viewing these topics. That's maybe the next session. I would say that interaction, what is the current level of research is going on among the postgraduates? They give me about the subjects you have taken. So that may be very interesting topic. What we have been discussing it, whether it is clinically applying or not, that will be very, very interesting. That will boost for the academic curriculum also. And that can be introduced in the next section. Only 2 hours we can give it. These topics we have been covered, and let them know that whether they will be able to apply in the clinical point of view. That's a very important this thing. And I don't want to prolong my speech. Congratulations to everybody. Thank you for giving the opportunity. From the AKSHAYA Dental College Research, I am sending our greetings from the director and chairman from the college. I spoke to them. They are also very happy to know that our college also involved in such a program. Thank you very much. And all the speakers and the guest speakers, everybody has done a wonderful job. And it is takeaway messages. We are now filled with the knowledge and the knowledge in our brain. And this has to be applied in the clinical scenario. That's very important. Whatever you learn from the literature or research work, that has to be applied to our clinical point of view. Our ultimate benefit has to be to the patients. That's our aim. Thank you very much. Thank you very much.
Thank you so much, sir. Definitely we'll take all your points into consideration, and definitely we'll, this PERIO AKSHAYA is not going to stop here. As the name itself implies, unlimited. We'll definitely make it more and more powerful and more energetic in future days with all of your support to come. Thank you so much, sir.
Thank you, sir, for your thought-provoking words, which are full of enthusiastic and valuable knowledge. Now I would like to request Dr. Victor DJ, sir, to address the gathering.
At the outset, just want to congratulate Dr. Gautami and Team Vishnu for an excellent symposium with stalwarts from periodontics and orthodontics to address the host of periodontists from across India to talk about the state of understanding of periodontics as well as perio-ortho interactivity that we ought to be aware of, And this is a great series of lectures that Dr. Gautami and Team Vishnu have thought to get to all periodontists to come together to talk about the different topics that need greater clarity amongst periodontists so that there will be a level of uniformity across all periodontists. And I think this has certainly gone a long way to provide just that there is a greater level of discussion amongst us as periodontists so that we have a certain level of uniformity amongst us, and whether it be the role of regeneration vis-a-vis implants, or whether it be where and when we are going to apply perioplastic surgery and root coverage more successfully, or whether it be how to perform orthodontics in the when there is periodontal disease, or how to evaluate the periodontium along with when orthodontic therapy is being conducted. So a realm of activity that has gained so much of clarity, and congratulations to the seniors who have been addressing. Dr. Nandakumar, who's the ever dynamic and so knowledgeable Dr. Nandakumar, who's always so keen to come to us with so much of his extensive understanding, and Dr. Vishwachandra, who has ever so wide realm of research that he wants to present to each one of us, Dr. Pauline and Dr. Vinita, who have been able to talk to us about their understanding of perioplastic surgery, and also Dr. Albi and Dr. Ravikiran, who have been able to so thoroughly be able to bring to us the state of knowledge of management of the periodontium during and before orthodontic therapy. So congratulations to each and every one of the thought providers and knowledge generators, as well as the panelists, Dr. Arun, who's ever so knowledgeable and ever so keen to highlight to each of us what we ought to be able to take care about, as well as Dr. Padma, Priya, and all the other senior members and who were part of the whole discussion today and yesterday. So thank you to each one of you, and we hope we'll have so much more of these interactions in the future. Thank you to one and all.
Thank you so much, sir. Victor, sir. It's always a nostalgic moment for me when like you're also a first batch of postgraduate from Bapuji Dental College. And I think we all share the same vibes, sir. Thank you so much.
Now I request our beloved Professor Dr. Gautami S. Penman, sir, to deliver the vote of thanks.
A very good afternoon, one and all. First of all, I would like to thank Vishnu Dental College for all the support. I would like to thank Vishnu Dental College for all the support it has been extending to us since its inception in the year 2002. From then, it has been growing in leaps and bounds. And today we are one of the finest institutes in the country and one of the best institutes in the states of Telangana and Andhra Pradesh. Without this college, we would not have been there for what we are. I would like to thank our beloved chairman, Sri K.V. Vishnuraju sir, for his ever enthusiastic support, and a man who believes in also in service to mankind, and education can definitely take a person to his next level. Thank you so much, sir. I would like to thank our beloved Vice Chairman, Sri R. Ravichandran sir, for all his everlasting and enthusiasm, which we are always fond of. I would like to thank our beloved director, Dr. Anand, who is also called as Dr. M.A.K.V. Raju, for all his support he has been extending. And he being an orthodontist by profession, but simple to say in a single sentence, he is a master of all specialties. And he is the one who strongly believes that knowledge has to be shared and education never ends, without which we always become rotten. And he is the driving force for all of us to get upgraded in our specialties and to be in a position of what we are today. Thank you so much, sir, for extending all your support at every level, providing not only a periodontal probe in all the other departments, but also providing a periodontal microscope and the dynamic navigation system and whatnot. Today, we have all the amicable or all the conceivable gadgets in dentistry, which we are able to work with. And all this would not have been possible with his vision and support. Thank you so much, sir. And then I would like to thank our principal, Dr. Suresh Sajjan, and our vice principal, Dr. A.V. Ramaraju, the periodontists, and who strongly believe without PERIO, Prosto doesn't exist. And they are the driving force for all the academic activities that we are able to do today in the department without any hesitation. Thank you. And a big thanks to principal and vice principal. Thank you so much, sir. And I get very nostalgic when I mention about my, not only my teacher, but my friend and mentor, Dr. Vandana KL, who have been associated with me since 1999, and who has always been my driving force and inspiration, and who is the one who has made me today for what I am, because always good teachers make or they know the best of students, what they can achieve or derive from them. Thank you, Vandana ma'am. And I would be ever grateful to Dr. K. Nandakumar sir, who has readily accepted my invite, even though we were not in contact for the last 25 years. I really remember sir seeing in 2000 when he was the first one to conduct ISP postgraduate workshop at Trivandrum, and that was the first year a postgraduate workshop or a postgraduate convention was conducted at Trivandrum. And I saw then sir as a very dynamic, and the same dynamism has continued since last 30 years, and still his passion for research and his passion for periodontics as such never ended. Thank you so much, sir. We always grew up seeing you, and you are always the driving force behind every periodontist at that point of time. Thank you, sir. Then our Dr. DJ Victor, sir, who is always a man of simplicity and humbleness, from whom I derive so much of inspiration, and the way he makes his students write the dissertations, or he makes them the master of periodontics. I heard from so many of my colleagues, including Dr. Prakash, who is always a down-to-earth person, and he always carries that vibe of Bapuji Dental College along with him. Thank you so much, sir. And our advisory board, comprising of Dr. Jaikumar sir, Dr. Faizuddin sir, Dr. Dwarkanath sir, Dr. A.R. Pradeep, Dr. T.K. Paul sir, Dr. Bongade sir, Dr. Suresh Chaube sir, Dr. Suresh sir, and definitely our madam. All of them have played a key role in meticulating this PERIO AKSHAYA to what it is today. And the expert committees, including Dr. Nimfia Pandit, Dr. Ravi Kiran, Dr. Baljit Singh, Dr. Janardhan, Dr. Manish Khatri, Dr. Vishaka Grover from the North Zone played a very important role in driving all the periodontists of that area and making this a success. And from the East Zone comes Dr. Balaji Manohar, Dr. Anandita Banerjee, Dr. Annapurna, Dr. Anurag Satpathy, Dr. Vinita, and Dr. Himadri Chakrabarti, who were always there backing PERIO AKSHAYA, and who always had their hand in every edition of PERIO AKSHAYA. And the West Zone, Dr. Bela Dave ma'am, who was always there in spite of her busy schedule, and Dr. Salika, my very good friend, Dr. Mala ma'am, who is ever there in spite of her busy schedule again, who is heading the Department of Periodontology at Nair. Dr. Monali Shah, a very young enthusiastic periodontist from Ahmedabad, and Dr. Abhay Kolte, the president-elect of Indian Society of Periodontology, Dr. Girish Baikot, who are very meticulous in their academic and clinical roles, and who always were there as a backbone of PERIO AKSHAYA. And last but not the least, the South Zone, from where even I come from, Dr. Anil Maleth, Dr. K.V. Arun sir, needless to say, all of us know who he is and what he is. And he has a lot of aura in the field of periodontology, and he's the most dynamic speaker and the most sorted speaker in the periodontal fraternity today. And the man beyond periobiologics, Dr. Vishwachandra, without whom the perio regeneration at this point of time would not have seen a new eye. And Dr. Pauline, I think most of you have heard her lecture yesterday on mucogingival surgery, and my very good friend and my senior, with whom I have seen periodontics growing up, Dr. Victor sir again, and Dr. Pallavi Samatha, who is a student of Dr. Suresh sir from Chennai, from Ramachandra, and who is very meticulous and who is very keen on the subject and is taking the Department of Periodontics at Vijayawada SNDC forward. Thank you so much, all the South Zone expert committee members once again. And Dr. R. Suresh sir, I will be failing if I don't mention about him. And I think I really don't have words to express my thanks to sir, because in spite of his busy schedule, and we know how busy sir is at this age, even after retiring from academics, he is a sole periodontist by heart and soul, who is working at present in IIT Chennai and guiding students of PhD there. And he was always there in guiding me, especially in PERIO AKSHAYA 2, and who had recommended speakers, Dr. Nandakumar sir, and he was always backing me up. And at any point of time, at any hour in the night, he was always there. And now also he's a very busy man. At present, he's really tied up with some ill health of his mother-in-law, but still he has made his presence in these 2 days of PERIO AKSHAYA. And his chief guestorial speech yesterday inspired many periodontists in the periodontal fraternity, wherein I got messages saying that it was so nice to see Suresh sir on the platform of second edition of PERIO AKSHAYA. Thank you so much, sir. And Dr. Gopal Krishnan, as I mentioned you yesterday, he is the man who is connecting the periodontal fraternity of India to the periodontal fraternity abroad. And he's the first one to do his PhD abroad. And now he's the Dean of DWeb Patil Dental College, Pune. And in spite of his busy schedule, still he never fails in guiding me and giving me advices, which I always take into consideration. Thank you so much, sir. And again, the speakers of PERIO AKSHAYA, Dr. Nandakumar sir and Dr. Vishwachandra, who really made the topic is flap surgery being undermined in this era of implantology a very interesting debatable topic, and who really didn't miss their balance at any point of time, because finally we are periodontists first and then implantology, and everywhere it's periodontology and implantology and not implantology and periodontics. And so they were very keen on maintaining the balance, and the session was the most crowd puller yesterday, because that's the most hot and debatable topic in the periodontal forum today. Thank you so much for accepting our invite and giving very valuable suggestions and advices just to the point. Thank you so much, sir. And Dr. Pauline and Dr. Vinita, who are the proud alumni of College of Dental Sciences, Davangere. Pauline, who is 1 year senior to me, and Dr. Vinita, who is 3, 4, 5 years junior to me, but still we share a rapport. Wherein, and Pauline is known for her mucogingival expertise in the field of periodontics, and Dr. Vinita again is known for her bone regeneration modalities and had done so many courses abroad. And both of them were very apt in delivering the lecture on mucogingival surgery, a boon or a bane to attach gingiva. And we are really indebted to both of you, because I know what stage you are in at present and how difficult it is to accept the invite and really do a wonderful job. Thank you so much. And Dr. L.B. Peter, sir, you are really our guest of honor or chief guest or anything. What I say is less, because an orthodontist accepting on a periodontal forum and readily accepting, and let me tell you frankly, as my director rightly pointed out, he is the most dedicated and disciplined orthodontist he has ever come across, even in Manipal. You really proved that one to be, because whenever I said, sir, I want the presentation today, he used to just send 1 hour before that. He was very, very disciplined and very timely in spite of his busy schedule. And sir was our second guest this time. First time he addressed ortho-perio colloquium, wherein I was really impressed by his talk on ortho-periodontal issues. And so I thought definitely we should not miss sir talking on this very debatable hot topic, that is ortho-perio consensus. And at the same time, Dr. Ravikiran also accepted the invitation very well. And both of you really justified the job. And thank you so much once again, Dr. LB sir and Dr. Ravikiran. And the moderators of the session, I would like to specially thank Dr. Anurag Satpathy, the young, energetic periodontist who is the professor at IDS Bhubaneswar, and who really played a very key role as the scientific chairman at the ISP conference. Recently, ISP held the conference, 46th National Conference at Bhubaneswar. Thank you, Anurag, so much for your kindly acceptance and for moderating the session so well. And our beloved Dr. K.V. Arun sir, without whom none of our program from Vishnu never comes to an end, because he has been a regular speaker since last 7 years in all editions of PERIO Avalokan. And as I told you, he's the most sorted out speaker in the periodontal fraternity today, but a very humble and very down-to-earth man from whom we as a young generation should really learn so much. Thank you so much, sir, again for accepting the invite on and online, because I know how comfortable you are on the online. Thank you so much, sir, once again. And the moderators of the session, Dr. Vishaka Grover, Dr. Salika Sheikh, again, were always there ready for me at any point of time to readily accept the invitation, and really moderated the session so well, because it was going so the discussion was so going heated up, but still they managed the session so well. And thank you so much, Dr. Vishaka and Dr. Salika. And again, our special chief guest, Dr. C.V. Padmapriya, the orthodontist from Vishnu Dental College, who is heading the Department of Orthodontics, and a very dynamic orthodontist. And I feel very proud when saying dynamic, because again, she's a lady, as all of us have a special consideration when we say that. But still, and she's very active at the student level, as she's also the Dean for Student Support Services since the college inception. And she's also an active member in the Indian Orthodontics Society, and consecutively holding the post of EC member at Indian Orthodontics Society. And thank you so much for moderating the session. And in spite of you and the other two orthodontists being there, you took up all the brunt of we periodontists. At the back of the mind, we really have what these ortho people have to do on the periodontium, but still you have really carried out the session so well. Thank you so much. And all this two-day program would not have been active. Actually, these pictures and these accolades across the country, these are only a few to put up. We thank all these participants who actively participated in the second edition of PERIO AKSHAYA, without whose support we would not have been continuing like this. Next. And here I have seen almost 99 to 100 participants, because the Zoom platform doesn't support more. And apart from that, we have a YouTube link also. I would like to specially thank Dr. Sharwanand, Dr. Vikendra Yadav from AIMS Delhi, Dr. Mala Dikshit, Dr. Rekha Rani ma'am, Dr. Faizuddin sir, Dr. Harita, Dr. Srinivas Nagarkanti, Dr. Juhi Rawal, Dr. Prakash PSG, Dr. Shivakumar, Dr. Raghavendra, Dr. Bennett Fernandez from Singapore, Dr. Amit Mishra, Dr. Amit Bharadwaj, Dr. Archana, Dr. Anurag Bhatnagar, Dr. Annapurna Ahuja, Dr. Jaikumar sir, Dr. Anil Kumar, Dr. Trinath Kishore, Dr. Vinita Singh, Dr. Vinayak, Dr. Veena, Dr. Padma Kumar, Dr. Rajesh Kashyap. And there are so many active participants. Sorry if I'm not able to mention every one of you in person, but let me tell you, without all of you, this would not have been a success. Thank you, one and all. And I would like to specially thank again Dr. Vishaka Grover, Dr. Harita, Dr. Gopal Krishnan sir. And it's just a recapitulate of the recent ISP conference held with one of our most promising mucogingival surgeon, Dr. Homer Zade, who is an inventor of many techniques in periodontics, and again, who was a really a man of substance in the periodontal fraternity, not only in US, but the whole world over. I would like to specially thank Dr. Harita for backing me up in all the activities. Thank you so much. And let me tell you, we are an organized team of Dr. Ramesh, Dr. Vivek, Dr. Mohan, Dr. Anusha, Dr. Kirti, Dr. Shrutima, who have always been very matriculated, very attentive, and very organized, without which all the programs coming from Team PERIO, and we are a Team PERIO, and without whom all this would not have been possible. And I am proud in projecting this, the Drive Force 15, the 15 postgraduates, and I'm so lucky to have 4 postgraduates as boys, because these days PERIO is totally dominated by the female postgraduates. The running around and everything will be done by them, but then the girls are also very active, and let me tell you, they're a very promising group of periodontists who are going to really see the world of periodontics and who are going to really be in our line very soon. Thank you so much. I would like to specially congratulate and thank Dr. Dinesh, especially for whom we are really owed to, because all the recording work, all the technical work, he's very well versed, and he really plays a very important role, especially in all the technical issues of the department. And I would like to thank Dr. Anurag for all the special invites that have been posting, without whom all this would not have been possible. And Dr. Kavya, whose voice you have been, I think it has been ringing in your ears since last 3-4 days, the trailer of the voice behind the trailer of PERIO AKSHAYA, who has really taken efforts in compiling such a beautiful video. Thank you so much. And last but not the least, Dr. Shravanti and Dr. Manisha, who have been the anchors of this PERIO AKSHAYA 2 since last 2 days. Thank you so much. And our dynamic and young computer associate, Mr. Bharat of Vishnu Dental College, without whom all this technical work would not have been really up to the mark, because he was the one who was opening the department from morning 8 o'clock, recording aspects and everything. He was the backbone for us as far as the technical issues are concerned. Thank you so much. And last but not the least, I would like to thank my support system, my husband and my twin daughters, without whose constant support and encouragement, all this would not have been possible. And finally, we Team PERIO thank each one of you once again for your wonderful support, for your time, for your energy, and for your participation, without which the second edition of PERIO AKSHAYA would have been a success like the first one. And definitely your cooperation and your support will make us more energetic and getting ready for the AKSHAYA third edition. Thank you, one and all. Thank you so much.
Thank you, ma'am. Now the platform is open for all the delegates to share their views.
And delegates can please fill up the feedback form that was sent to you. And please, any one of you can really share your views. It need not be always appreciations, but it can also be critical comments, so that we can improve on this program.
Hello, guys. Good morning. I think as a delegate, as a good friend, as a teacher, whatever you want to call me, I'm there with the whole team of PERIO, Vishnu Dental College, and the wonderful support system she has from the management, everlasting support. I am so proud to say that I'm a part of this Vishnu Dental College PERIO supporting system, and as a tooth organ, as Dr. Nandu said. And I always used to call him Dr. Nandakumar. No, it was Dr. Nandu sir, who was my co-examiner during my early days of my postgraduate teaching in Bapuji Dental College, who has been a strong force, who has been a very encouraging person, because I was very young, probably I was just about 23 or 24 years. And he was with me for several MDS examinations, and always an appreciation for the work that has been done at PERIO department, Bapuji Dental College. And he gave the best of the periodontics to the the entire nation, I should say, whoever is not there today, they have missed it. And the lovely the follow-ups that he has done. And I think that is a real eye-opener study speech by Dr. Nandakumar. I really congratulate you, sir, and appreciate you for that wonderful collection of patients with the, I would say terminal cases. And then even then you are able to go ahead with that. And all the photographs, and they were just with all the follow-ups that you could show it either radiographically or as a clinical investigations or clinical follow-ups were too good to believe and too good to understand and too good to cater it to the world of periodontics from Indian scene. And it rarely happens from the global world. And it usually we see only few certain things which is always followed in a wrong way from the global front. But from India, the best, and then you are the best, which we could have it. And not to all the girlies of my COTS Perio team, I'm very proud, very honored, very respected that Gautami to organize such a brainstorming, brain teasing sessions that which is the need of the hour. And she could really plan this well, whether the topics, because without which the whole of the implantology is trying to gulp, take away the whole of periodontics in a strong way. And I would not recommend it. I'm not against implantology, but the way it is engulfing the whole of periodontics is very, very disheartening and very disheartening. And then our own periodontists should be woken up in such a way that you got to practice periodontics, nonetheless later the implantology. And that is very impressive talk by Dr. Nandakumar and Vishwa, and who could really made it strong, say that we still are periodontists, and so proudly it was given a chance to say that implantology should be the last one to be referred as. And I too recommend this, and I hope you all get this into your, and then try to be doing the best of the job. And next the set of girls, Pauline and Vinita. Vinita and Pauline. Vinita started the basics of attached gingiva, lovely. And she never left anything regarding attached gingiva. And then taken over by Pauline, who had a presentation with evidence-based and her own set of cases. Again, very proud moment for a teacher to see all that. And then she could stand by all the discussions that was given to her. And both of them served the best of the information to the listeners who are a part of this. And I felt, again, I repeat, very respected with 3 girls around of my own, the branches of COTS Perio. Okay, thanks a lot, girls. And Ravi Kiran, and of course, he's been a very youngster coming up with a lot of good information regarding several topics, and this is one of them. And I always know him for serving a lot of books and journals to us as on the WhatsApp messages, and I always appreciate him for this. And then today's performance, and LB Peter, always, yeah, I've just heard him twice, and today I could just really get him how best he could serve for periodontics. And I owe you a lot, sir. Orthodontics and periodontics are very close friends, and we have to respect each other. And that's why the whole of the service to dentistry through periodontics and orthodontics can be held hand in hand. And this is how these kind of sessions are very important for anyone to go ahead, whether a senior or junior or a middle, whatever the age group you belong. Especially the youngsters, wake up, follow the periodontics, also implantology, and also be the interdisciplinary person to help each other to make the periodontics better. And without periodontics, we don't survive. And we are always at the receiving ends, unfortunately, but we are the givers actually. We always give a lot of things to the whole of dentistry. So with this note, I congratulate Gautami, Gautami. I say 3G Gautami because go-getter Gautami, I say. Huh? She's 3G for me. And then, of course, we are in the era of 5G in India. It has just started to be there. Maybe she will add another 2Gs to that. Our great and, wholesome grandson, Gautami. And then the team. I'm so happy to say the whole team consisting of PERIO is been I also feel that I belong to them. I belong to them. Yeah, that's what I feel. That's what makes you feel that I'm a part of these sessions without fail. I was just outside, went for a marriage, but I said not to miss her valedictory function. And I heard her whole lot of vote of thanks. She never left even one stone unturned. Not even one stone unturned. Very, very meticulous. Thanks a lot, Gautami. Keep it up. Many people cannot do that, and you do that and show it. And proud to that. I'm sure your management is very proud of you. And then I'm sure they will still support you. And that's how I can see you growing still better, and reach the best of the heights. Okay. And this is what I wish if there is a bottom or the whole of the heart, the best of wishes to the whole of team of PERIO from Vishnu Dental College, all of you. And then next, the management management without the serving as a backbone for you. Yeah, they have been very, very supportive for you, starting from Vishnu Raju sir, Anand sir, and MKV. I think I'm a little this thing, Raju sir, and your own husband, Raju, who is our alumni again, and Sajjan as a principal, who is our good friend. Take care, all the best, and do some more of these, which are eye openers. They're eye openers and mind teasers. Thanks a lot. Take care. All the best for all of you. Take care. I end up here. Yeah.
Thank you so much, ma'am. You're always a part of Team Vishnu PERIO, and that goes without saying, and undoubtedly. And let me thank my college of both colleges where I've been a part of Davangere for 10 years. Both Bapuji Dental College, where I did my undergraduation, and College of Dental Sciences, where I did my post-graduation. And both the colleges molded me and grounded me to the level what I am today. And definitely, madam was a total inspiration for me. And a few more inspirants are Dr. Suresh sir, Dr. Nandakumar sir, and in PERIO fraternity, we grew up seeing them. But unfortunately, madam never is available offline. She's available only online. So that's the reason we couldn't catch her all these years. But still, nice seeing you, ma'am, for all the initiatives from being a part of all the initiatives from Team PERIO. Thank you so much, ma'am.
Hi, good afternoon, Gautami. Vishakha
Yeah, good
here.
afternoon. Yeah, Vishakha, good afternoon.
Just want to say thanks, a big thanks, and a lot more congratulations to the team PERIO at Vishnu Dental College for hosting this event. I really appreciate heartily your commitment and effort to bring in PERIO AKSHAYA. That makes us, all of us, interact online, and bringing in these brainstorming sessions is really a good addition. We need it. So that makes me, that makes it possible for us sitting at this end to interact with everyone there. So very happy to be a part of this, and many more congratulations and many more additions to come. So all my best wishes. Very well conducted program. Thanks a lot. I'm proud to be a part of this. I'm proud to be in touch with so many stalwarts of PERIO, right? So that's all from, I'm in travel today. So again, I just logged in to say thanks to you and to congratulate you. That's all from my end.
Thank you so much, Dr. Vishakha. In spite of your busy schedule, you were always there with we Team PERIO at Vishnu.
It's a pleasure to be a part of the team. Thank you.
Thank you so much once again. Anyone want to share your views? I can see Dr. Sriniwas Nagarkanti, Dr. Prasad Mandav. Feel free.
Ma'am, it's an excellent presentation, ma'am. So I'm happy for the first time, me being the head of the department here, So first time attending this conference here, this workshop. So for inviting, and it's a very pleasure for me to be with you all. Thank you.
Hi, Gautami.
Hi, Samata. Nice to hear from you.
Yeah, thank you so much for making me a part of this first. You and your team. The best thing about whatever you are conducting is the persistence. It could be PERIO, Avlokan, or PERIO AKSHAYA. The team effort is excellent, and each time you nail it. So I think your effort is shown here. The discussions were awesome. The knowledge, especially when I hear to all the seniors like Nandakumar sir or Arun sir or anybody, still we learn something there, some point, 1 point. So it is so good, so good. And the discussions were so good, perfect. So congratulations to your whole team. And I genuinely hope that the many, many years of this PERIO AKSHAYA going on. Thank you.
Thank you so much, Samata. Thank you so much for the support.
Yeah.
I can see Dr. Bernard Fernandez. He doesn't miss even a single session of anything coming up from Team PERIO at Vishnu. He's the one who is academically attached to a university in Singapore. Dr. Bernard, sir.
Thank you very much, madam, for this wonderful platform to be here. I really like the interaction which happened, and I think because of the fact that postgraduate students weren't around, we felt a little bit more free to discuss our doubts, to see the high level of interaction between, I think from the length and breadth of the country, all the people have been interacting. And over 2 days, I saw that there was really fantastic. I couldn't be a part of the first one, and I think now, oh, I really missed something, but I hope to definitely be a part of the third one, which I'm sure will be happening in the future. So fantastic discussions, a lot of inputs, a lot of insights from both very experienced people, a lot of interdisciplinary inputs also, and how we can improvise, especially now with the new clinical practice guidelines coming in for the stage 3 and stage 4 periodontitis. So naturally, ortho again comes back into vogue, especially with a lot of people back into adult orthodontics also. So yes, really nice. Thank you very much, madam.
Thank you so much, Dr. Bennett, for always being a part of the team. Thank you so much. I can see Dr. Rupali there. Dr. Rupali. Shall we wind off? Thank you so much once again for all of your time, energy, and for your presence in the 2 days of PERIO AKSHAYA. Please don't fail to fill in the feedback form, because it will help us to serve you better. Thank you, one and all.
Thank you.
Thank you so much once again.